मिथिलेश अंडर हो गया मिथिलेश अंडर हो गया
Yeah.
हाँ बोलिए
Hello, everybody. Hi to this yet one more live surgical event on mucormycosis. Uh, as we know, like COVID itself, even mucormycosis is as much a medical and a surgical problem as it is a social and an administrative problem. So we had, in fact, I had on my own reached out to the political governing people because we need their help in very many things to be able to deliver a cure to our patients. I mean, honestly, we can only do only that much as a surgeon, but there is so much more that we need, right from the availability of the drugs to at this scale, public education and having policies in place and other things. Everybody is busy. We have Dr. Shrikant Shinde, who is a member of the parliament, and we are lucky to have him here. He's from Thane. Among the government representatives, he's a medical doctor. He's our fraternity, plus a member of the parliament. So he will be there watching very alertly. We had planned to give a talk mainly for the chief minister of Maharashtra and the urban development minister, our dear Eknath Shinde, for them to hear and understand, so that the policies that come forward can be very strong and very patient-centric to the scientific thing. Because see, COVID we have still not understood, we never understood, but mucor we have understood. We can cure a mucor if we apply and we've been doing this for many years. So mucor is not new to us. The scale is very big. The challenges coming with the scale are very big. But with this background, I think it was my effort to bring in the political leaders, and I hope they will come and join at some point. Please
Yeah,
bear with
Minister,
us that if
Dr. Bhumkar, Minister sir will join in the next 5 minutes. And
5 minutes. Okay.
Yeah, and he's coordinating with Chief Minister also.
Oh, okay. So maybe like I said, in the next 10-15 minutes. So Satish, you can start with the first MRI because we don't want to encroach on the academic content. Yeah.
correct karo okay Ashish thank you
Thanks.
so again I welcome you all to this big day with like Ashish said this COVID is it requires a lot of efforts from the governance also to control along with the doctors. So today is a big day for a country setting a big example by a government to fight with this dreaded disease, mucormycosis here. So, sir is joining in couple of minutes. So meanwhile, I'll take you through the MRI of the first patient we are taking up today. Last time in the last webinar, we had discussed a little about the MRI. See, for a mucormycosis successful treatment, the most important thing is the successful diagnosis, and correct extent of disease. The reason being, the role of surgery is very, very important in terms of debriding all non-vitalized necrotic tissue. And then the role of the medical therapy is important to take care of the all vascularized area involved by the fungus. So the can be successful only surgery can be successful only when we have a full information about the tissue to be debrided. Now there are many radiological investigations, like a lot of people talk about CT scan, MRI, and other investigation, PET scan, and all. MRI is the gold standard for reasons I am going to enumerate. CT scan is simply something which gives details of the bones but doesn't differentiate the soft tissue into what exactly it is. Like it could be secretions, it could be some fungal infection, it could be tumor, it could be anything. It will just show an opacity, nothing more than that. MRI, by means of its, variety of sequences it can provide, it is so versatile. MRI can give more than 1500 sequences, each having its own value in describing some details. So by means of various sequences of the MRI taking into consideration, we can clearly differentiate the variety of soft tissues, what it could exactly be. And that is how the MRI is the gold standard for diagnosis as well as describing the extent of involvement by the mucormycosis, which tissue is necrotic to be debrided, which tissue is enhancing on contrast, which need not to be debrided. Yes, you can debride to reduce the fungal load, not necessarily at the expense of loss of function. Like, for example, some enhancing areas are there in the cavernous sinus, at the orbital apex, at some critical areas where debridement can lead to lot of function, loss of function. You can leave them for antifungal therapy as it will penetrate as the gadolinium is penetrating by means of showing enhancement. So the goal is to describe only those areas which are necrotic, non-enhancing, where gadolinium is not reaching, and there is no other tool than the surgical debridement to cure that area, because that tissue is lack of oxygen. That is acidotic area where is no blood supply, and that is where the fungus thrives like anything to the surrounding neighboring areas. So that need to be debrided earliest to prevent the further complications of the mucormycosis to the distal areas like orbit, brain, or anywhere. So once comes to MRI, first of all, what kind of MRI to be ordered and how it is ordered?
So
A
in
lot of
fact,
queries last time we had.
Satish, if you don't mind, I think
Yes,
that the CT scan can actually be misleading. And if you base your surgery on a CT scan, you are
yes,
actually end up doing an incomplete job.
yes. That's what I'm coming to. Ashish, your point is valid.
Yeah.
So, first of all, Ashish, last time we had a lot of questions which were unanswered.
Correct.
But what lot of people are wondering, what kind of MRI sequence to be ordered? Why this question is existing? Because you can't write that MRI PNS.
Hmm.
I already mentioned MRI as versatile in providing n number of sequences, and every sequence has to be acquired separately. That has to be shot separately. So MRI takes a lot of time. We need to write on our prescription that we want these sequences in these planes. Otherwise, what happens? If you write MRI PNS, the radiologist will finish in 5 minutes by giving one or two sequences which may not be having any value for us. So, proper diagnosis, detailed information, the onus is on the surgeon to order what kind of sequences to be. Got my point?
Yes,
So,
absolutely. Yes.
the surgeons must know that what sequences are to be ordered in cases where what you are suspecting. For mucormycosis, the sequences we ordered is a T2 weighted multiplanar MRI, T2 weighted suppressed multiplanar MRI with contrast multiplanar MRI, 3D contrast, which is 1 mm. The routine contrast, see this routine contrast is 3 mm. For in case you need a navigation or something, you need a fine section which requires a 3D contrast, and diffusion weighted imaging for early diagnosis of any infarctions in the brain. This is very, very important. You know what happens? This mucormycosis is a progressive disease. We have experience in our practice. Patient already had infarction in the brain, which had an effect on the general condition of the patient. On MRI, on routine MRI, kiska mobile? On routine MRI, it was not discovered because the diffusion weighted was not ordered. So on routine MRI, the mucor extent was assessed and operated, and day after the patient deteriorated neurologically, and then MRI revealed infarction. It was an earlier infarction which has progressed because of overlooking that fact, not counseling the patient, and it can be a major reason for medical legal problems also to the doctors in case they overlook such an important finding. So we must order diffusion weighted MRI in all cases of mucormycosis because it is prone to give distal infarction in the brain, sometimes even in the early in the stage. Then the next sequence to be ordered is the MR angiogram. That is very, very important. We all know mucormycosis has a tendency of angio invasion. It invades the vessel and gives distal infarction, distal thromboembolic episodes, and that is why we not very uncommonly we see multiple infarctions in the brain, thrombosis of the carotid artery, hemiplegia, and many other things. MR angiogram in detail will depict any such event happening at that point of time when you are treating the patient. And if it is, you can take your call accordingly, counsel your patient, take the help of neuroradiologist, take the help of intervention radiologist, take the help of neurosurgeon, neurologist, and so on. Here, disconnect to one. Sir, this one. Yeah. Can you hear me?
We can hear you, Satish. No
Yes,
problem.
yes. So the question is, we need to order a proper MRI, and then how to acquire all these sequences. See, for all these sequences, what I told, it takes at least 1 to 1.5 hour in acquisition of the entire MRI. And what happens if you order an MRI PNS, some radiologists can do in 1,000, 2,000 rupees, finishing in 5 minutes. But mentioning all these sequences will require a proper effort and time and will take almost 1.5 hours. So this costs as well. So this is to be understood that MRI costs a lot because of the time. A machine cannot do more than 20 to 30 MRI if all these sequences are, taken properly every day. So the second thing is how to get the entire information.
But one of the ways to keep the cost under control is to not ask for the films and ask for the CD.
Yes,
That
that's what
will
I'm coming to. That's great.
exponential. Yeah.
See, the sequences, number of sequences I mentioned will require more than 3 to 4,000 slices. Now, a printout carries 15 to 20 slices. How can you carry 3 to 4,000 slices, and how can you see one by one after that? You can't see them in order. It is impossible for a patient to carry a bag of kgs to carry the MRI. So, the simplest way is to have this information in a DVD, in a digital form, and that is what I am showing here. See this MRI. The most important thing is, ये कैसे आ रहा है short lose connection है यार. Do something. इधर आओ. Some loose connections. Sorry. इधर आओ. आगे आ जाओ एक जगह. ये देखो. Where it is? Gone.
Sorry, Satish. Bolo.
Hello.
Hello. Yeah. Yeah, Satish.
You are audible.
पूरे ही गया.
We can hear you, Satish.
Is it going live? Ashish, can you hear me?
Yes,
We can hear you. We can see you.
I can't hear them. Just a minute, please bear with us for a moment.
We can hear you. Shinde Saab had called. They are joining in some time. But he said, please go ahead and start your surgical work. What happened? We can hear you. You keep talking.
वीरू को बुला.
I think he can't hear us.
Do something quick. अरे वो आ गए यार. वीरू को बुला दो. और तुम लोग मौके पे.
Yeah, I think this because there's a lot. I've been talking to many people, and they're saying no. Please don't advise MRI as a standard, gold standard. It will create a lot of problems, especially in medical colleges and medical hospitals. But there really is no shortcut to this. In fact, the basis on which this mortality is very high is because based on a CT scan, when you plan and perform your surgery, you are invariably likely to leave the, because this is traveling through blood vessels without destroying the bone. The tendency is if you see a healthy posterior maxilla, you imagine that everything behind that is normal. And that is precisely where things have been going wrong earlier, and therefore the mortality reported has been 50 to 80%. If you do the MRI workup and clear away all the debris, the amphotericin can then now reach the and kill the virus.
Ashish, a question.
Yeah.
In a dentist, if the lesion, at what level that you should advise MRI? I mean, if the invasion is not much clinically, or if you see in the X-ray, do you think that you should advise MRI to all the cases?
Yes, unfortunately, yes, all, because you may see a tiny that will be just the tip of the iceberg. So it does not spread by contiguity. It is not like everything in the way is going. So you may see a sign here, a sign there, and it may be deep inside. And it may not cause symptoms. I mean, for it to cause any neurological deficit and all, it is a different story.
It has to have spread a lot before it will start showing up with neurologic symptoms.
And unless you remove the entire necrotic tissue, the amphotericin is not going to work.
Then post-operative, do you think MRI is also necessary to see whether you have taken out everything?
Yes, sir.
Yes.
Theoretically, yes.
Yes.
But there are blood parameters like ESR and CRP that we manage, and then there's an overall clinical. But typically 10 days, around 10 or 15 days. But in that case, one need not do such an extensive MRI, because now we know which areas to come.
Yes.
Coming out
See,
with,
Ashish, this is a very important point that sir has raised about the need of repeat MRI in the post-operative period.
Yeah.
See, our goal is to completely debride the non-vitalized tissue. If that goal is achieved and the antifungal therapy is induced, patient is likely to improve very fast. Now, you have to keep certain things in mind. The clinical condition number one, if it doesn't improve, that means there could be something lacking behind. Number two, like Ashish has mentioned, the inflammatory markers. CRP is a very sensitive marker. The moment you debride and institute antifungal 3, in a couple of days, the CRP comes down like anything rapidly. If, on the contrary, it still keeps on increasing, it indicates that something is remaining. There is something behind which has not been debrided. And that is the time, if the clinical condition deteriorates, CRP continuously increasing, the radiology has a huge value. We have revised our couple of patients on this basis and found some disease behind. See what happens during the primary surgery, looking at the MRI, your focus becomes very narrow to that particular part, and you overlook certain areas which were not picked up initially very well by the MRI. And that, if it increases, it will result in lack of improvement of the patient's markers and the patient general condition. And the repeat MRI is very, very useful, vital. You can go back and debride that particular region and the patient improves. So that's a very valid point to keep in mind, the possibility of getting the MRI repeated and possibility of a repeat surgery in the post-operative period if the need arises.
That scenario, you don't need this thorough, all the sequences.
Yeah. So now,
Screening
see the
MRI.
two sequences I am running, two most important sequences. I'll come to others further. This is a T2 weighted MRI, the first one. T2 weighted fat suppressed MRI. We all know fat is bright in all sequences of MRI. Any sequence of MRI, fat is bright. So this is a fat sequence MRI, T2 weighted where the fluid is bright. Inflammation is bright. Any inflammation, it is bright. Any liquid, it is bright. See the CSF intensity, it is bright. On the side, along with, this is a contrast MRI to see where the gadolinium is going. Now, if we compare these two sequences, now, right from the beginning, let me come from here. See the condition of the globe on this side, this is bright on T2, dark on contrast because globe doesn't enhance. Now, as we go in, can you see the lack of contrast areas, lack of contrast enhancement in the turbinate? See the lack of contrast enhancement in the turbinate, which is quite suggestive of this lack of vascularity, which is common in mucormycosis. And this mucor, typically at the first stage, initially it affects the turbinates. The lateral wall and the turbinates are the structures which are initially affected. Nasal septum very commonly initially affected. And then if we go to the orbit, look at the condition of this orbit on this side and orbit on this side. Can you make any difference?
Huge, yeah.
There's a huge inflammation going on. There is no fat. This is fat suppressed. Huge inflammation going on, and this variable intensity of inflammation as compared to the normal orbit is quite suggestive of this orbit being full of disease, full of mucormycosis. You can make out very clearly with the help of MRI. Now come to the CT scan, like Ashish raised the point. What would you see on CT scan? Simple opacity. You cannot differentiate what exactly is going on. So this orbit to me is completely involved. See the variable intensity, the level of inflammation, the level of dark spots, which is dead areas, level of bright spots, which is more inflamed. And this orbit overall is this patient has a blind eye, the left eye is blind in left eye. And this kind of inflammation, which is enhancing on T2 weighted fat suppressed image, it quite suggestive of disease filling the entire orbit. And this is a case, ideal case for the orbital clearance. Now, this is our first case. Today we have variety of cases. Last time somebody was asking about the palatal removal. We have a case for the palatal removal, case for the extensive sphenoid drilling for the pterygoids and the sphenoid bone. So to add on to the variety. So this particular patient to begin with has a minimal, you'll find a disease in the nasal cavity except this necrotic areas, some disease in the ethmoids because of the obstruction, and then the orbit is completely involved on the left side. That is classical presentation of the mucormycosis with blindness in one eye. And this is complete involvement. The other presentation of the mucormycosis in blindness is not having any visual disease, but central or retinal artery occlusion. This is another presentation which is less common than this kind of extensive involvement of the mucormycosis of the entire orbit. See the lack of mucor tissue into the orbit, non-enhancing areas into the orbit, which we are going to debride. Like last time I had shown one debridement, orbital clearance, and this is the same case requiring the orbital clearance. And this kind of pre-operative assessment can help in counseling your patient as well, that this orbit will require a clearance. Now, a lot of questions last time about the orbital exentration. Orbital exentration is a radical terminology actually reserved or introduced the terminology for the malignancies involving the eyeball, eyelids, and orbit tissue as well, which involve radical clearance of the eyeball, periorbita, entire retroorbital content, eyelids, eyelashes, everything. That is orbital exentration. This is not a malignancy. Here the goal is different. Here the goal is to remove only devitalized tissues, nothing else. And this will certainly not require a orbital exentration in this kind of a situation where your eyelids, eyelashes, the rest of the other tissues in the globe is actually normal. So we need to remove only devitalized, this lack of devitalized tissues which is collected into orbit because of the lack of vascularity. So this is about these two sequences. Now you can, once it comes to the contrast, you can take the contrast in all planes. How can you take the 3D? 3D contrast is a useful situation, useful sequence. This is contrast in all three planes. This is 1 mm, less than mm. Sometimes we get 0.6 mm, and this is useful when you are using the navigation system along with when you're working at the skull base for added safety, for added insurance that you are going to complete the disease clearly, particularly when it is along the vital structure. There is, you can use this 3D. You can see all planes moving once I take my cursor everywhere, and you can better, orient yourself with the anatomical surroundings. So this is the 3D.
Run us through the pterygopalatine fossa and the infratemporal fossa.
Yes.
Yeah.
Yes. See, pterygopalatine infratemporal, you can get to know from any of these sequences from the coronal and the sagittal and axial. See, this is the maxillary sinus.
Yes.
I am going behind. This is orbit. Going behind. This is the maxillary sinus ending, and this is the pterygoid fossa, pterygopalatine fossa behind, communicating to the orbital apex. That is how the disease, last time I had shown,
Yes, the superior orbital
disease in the pterygopalatine fossa, having blindness, pterygopalatine fossa looking, the posterior wall of the maxilla looking normal from front, but having disease behind, which led to blindness. So all patients having blindness, you must look into the pterygopalatine fossa thoroughly to go to the orbital apex, which is involved for the reason of blindness. So this is how the MRI helps. Then the MR angiogram and the venogram. MR venogram and angiogram helps you to see the venous and arterial thrombosis. These patients have a tendency to have very commonly. This is time of flight MR angiogram sequences. See this. This is the carotid artery.
Yeah.
Carotid artery, the course of the carotid completely. Yeah, this one is complete. See the horizontal petrous carotid, foramen lacerum carotid, the cavernous carotid, and now the carotid terminating into anterior and middle cerebral vessels with complete information about the circle of release. So that is provided by the MR angiogram. If there is any thrombus obstructing the carotid artery or its distal branches, MCA branches causing problem or infarcts, one can easily see by means of MR angiogram. And this particular, fungus has a tendency of angio invasion, where we have to be very carefully evaluate, order this sequence and evaluate in all cases. Then the next one is a diffusion weighted.
Can you run the internal intermaxillary?
Internal maxillary. If you run internal maxillary, actually I can show you on T2 weighted also, in case required, as a flow wide. This is internal maxillary artery in the flow wide. See the internal maxillary artery running. You can see on T2 weighted as a flow wide. Now coming to a very important sequence, that is diffusion weighted MRI, which should be ordered in all cases. Where is diffusion weighted MRI? Diffusion weighted MRI, see, this is the sequence which can pick up if there is any infarct at the earliest. This is basically meant to see if there is any infarct or any infarcts developing at that point of time when you are taking up the case. And this is very important to know from the diffusion weighted if any infarct which is in the developing form, so that you can warn your patient about the future deterioration, warn about the poor prognosis, warn about the neurological complications which may arrive in the due course of time. And that is an important sequence to keep in mind for every case. So diffusion weighted angiogram, T2 weighted fat suppressed contrast, 3D contrast, all these are the sequences which are, I would say, are essential when you think of workup of a mucormycosis case radiologically. Yes, Ashish, anything?
No, Satish, in
Yes.
view of the extreme angio invasion, what is your protocol for creating the anticoagulation? What is the anticoagulation protocol in such?
See, yes, anticoagulation definitely helps, but pre-operatively you can't start anticoagulation. So now the time is to counsel your patient if he has developed such kind of complication. You need to remove the basic cause, that is the mucor in the paranasal sinuses, orbit, wherever it is, for a radical clearance, and then put the patient on anticoagulants and vasodilators for the improvement of the circulation, to take care of the prevent the thromboembolism and further complications.
Is there any role for papaverine and other vasodilators in such situations?
Actually, the situation here is not vasoconstriction, where the papaverine can help. That's a different thing altogether. In this situation, it is the thromboembolism which is more important. So anticoagulants are more important, more relevant, and low molecular weight heparin is the key in preventing complications. So the radiology.
One more question is, as far as the bone invasion is concerned, how do you judge the endpoint of your bone removal?
Yes, that's very important. We will see during surgery as well. See the bone invasion, how it will look like. Avascular bone, osteomyelitic bone without bleeding. The moment you debride this avascular bone and you reach to an end, you will find a bleeding bone, a plate of the bone with a soft tissue structure behind, showing the end of the debridement, end of the bone removal, and more importantly, wherever you start finding the vascular bone which is bleeding, that is the end point of drilling. In a normal clivus, normal sphenoid bone, it is so vascular.
Yes.
Like, for example, I give you for a transclival approach, when you start, drilling the clivus, it bleeds like anything due to multiple venous and vascular channels. It is in a normal situation so difficult to carry on in such situation that sometimes you have to stage your surgery, you have to use a lot of maneuvers to stop bleeding. In this bleeding, you have seen last time and we'll show again today, this osteomyelitic avascular bone is no bleeding. Will keep on drilling, you will not find a single drop of blood suggestive of an osteomyelitic bone. The look of the bone, the feel after drilling, lack of bleeding are the signs of a bad bone that need to be removed.
Yeah.
And this inadequate debridement cannot be covered by antifungal therapy. That is something important. That's why the mucormycosis is considered to have a high mortality, because the lack of adequate debridement. The single most important reason. Reason being, if you have left behind the osteomyelitic bone, sometimes it is really difficult to remove because the sphenoid bone is so strategically located in the center of the head with a lot of neurovascular structure running through it, a lot of neurovascular structure around it, and with a bone which need to be divided with the carotid artery, optic nerve, lot of nerves, cavernous sinus in the close vicinity is really a big challenge, particularly for the and the surgeon is not very experienced. And obviously, to prevent any complication, your strategy would be to leave some bone around rather than giving complications and then resort to antifungal therapy. With a dead bone behind, invaded by fungus, with and antifungal therapy on, you can't expect any kind of improvement. And what is going to happen? The condition will deteriorate and ultimately such patients die. So, for a successful treatment of mucormycosis, the preoperative assessment of the bony involvement and adequate debridement is the key to success. These two things are important and key for the successful antifungal therapy as well. Whatever antifungal therapy you are giving, if the dead tissue, osteomyelitic bone, or anything is left behind, these are not going to work. And that is the area which is most favorable, most hospitable environment for the fungus to multiply. So that is where we need to keep an eye to debride such bone to prevent complications.
One more point is that we often use C-reactive protein, CRP, on alternate days as a sort of prognostic indicator. What is your view on procalcitonin also?
Yes, procalcitonin is a very sensitive marker for the bacterial infection. Very large. We never use or never advocate this for the fungal infection like mucormycosis. CRP is an overall inflammatory marker. It doesn't discriminate what kind of inflammation it is. Suppose you have treated a mucormycosis patient and still you have not opened all sinuses. There are some blocked sinuses with purulent discharge within them. Some other infected area which you have not addressed may not be mucor. Still the CRP level will be persistently elevated. So this gives an indication that something is lacking in your treatment. The treatment is not up to the mark, which is not allowing the CRP to come down. So this is a very, very important clinical sensitive marker and a very, very cheap test you can get done in 10-15 rupees anywhere in the laboratory. Yes, Ashish.
Satish, our Shinde Saab, our UD minister, he's here, he's our Thane Guardian minister and is really in the top. He's already linked. He's trying to make one final connect with the CM. Otherwise, we'll have him sort of inaugurate or announce this. I just spoke to him. We are trying to, there's some, I think, communication labs from my side actually. Because, Namaskar, sir. This is Shinde, sir. Namaskar. Rahul, thank you for joining also.
राहुल जी आहेत सगळे आहेत.
राहुल जी आहे, शशांक पण आहे, आता तो साधला गेला.
नमस्कार सर.
नमस्कार
Sir, thank you so much. आणि काल जरा slide. Satish, can we go to the other presentation?
Yes. Okay.
नाही, एकच मिनिट. आशिषजी,
हो हो सर.
खरं म्हणजे मुख्यमंत्री महोदय पण स्वतः जॉईंट होतो म्हणाले होते.
हो
मुख्यमंत्री महोदयांनीच मला या संदर्भामध्ये आपल्याशी बोलायला सांगितलं होतं
हो
आणि आपलंही बोलणं त्यांच्या बरोबर झालं
हो
की म्युकरमायकोसिस जे आहे अतिशय म्हणजे जो काही कोविडमध्ये होणारा जो काही आजार आहे त्या
हो.
बाबतीमध्ये आणि त्याचं काय जे डेथचं प्रमाण आहे या
हो.
सगळ्या गोष्टी लक्षात घेता ही थोडी काळजीची बाब आहे आणि चिंतेची बाब मुख्यमंत्री महोदयांनी मनावर हे सगळं घेतलंय
हो सर.
आणि त्यामुळेच त्यांच्या मार्गदर्शनाखालीच आज आपलं हे आजचं जे काही आज आपण ऑनलाईन ही बैठक बरेच डॉक्टर याच्यामध्ये सहभागी झालेले आहेत आणि आपण सातत्याने ही सगळी टास्क फोर्स जी आहे आपली स्टेट लेवलची ती देखील सातत्याने यामध्ये काम करते आहे आणि रिकव्हरी रेट वाढवणे, डेथ रेट कमी करणे, प्रोटोकॉल, गाईडलाईन ह्या सगळ्या ज्या काही गोष्टी आपण करतायत सगळेजण त्याबद्दल मी युडी मिनिस्टर आणि पालकमंत्री म्हणून आपल्या सगळ्यांना मनापासून मी धन्यवाद देतो, आपलं मनापासून स्वागत करतो आणि मला वाटतं हे त्याच्यामध्ये हे नवीन म्युकरमायकोसिस आलेलं आहे त्याच्यामुळे आपल्याला त्याचा एक सामना करायचा आहे आणि ते सगळे तुम्ही सगळे एक्सपर्ट आहात त्यामुळे हे जे काही सुरुवात कुठून होते काय होते त्याच्यावर मी काही भाष्य करत नाही ते आपण सगळं सांगाल आणि याच्यामध्ये कोविडमध्ये त्याच्यानंतरचा म्युकरमायकोसिस जो आहे आजार होऊ नये यासाठी झाल्यावर आपल्याला ट्रीटमेंट करायचीच आहे परंतु होऊच नये यासाठी देखील आपल्या सगळ्यांचा प्रयत्न असणार आणि तोच उद्देश डोळ्यासमोर ठेवून मुख्यमंत्री महोदयांनी आपल्याशी आणि इतर आपले जे टास्क फोर्सचे सगळे तज्ज्ञ आहेत त्यांच्याशी चर्चा केलेली आहे त्यामुळे भूमकर सर आपण मला वाटतं सुरू करा.
तर तुम्ही आहात इथे म्हणून सांगतो की होऊ न देण्यासाठी आपला शशांक, राहुल आणि हे सगळे जे फिजिशियन लोक आहेत शुगरला रोजच्या रोज वाढूच दिली नाही तर म्युकॉर गेला समजायचा. म्हणून तुम्हाला भेटलो की 100 दिवसात महाराष्ट्रात म्युकॉर नाहीसा कारण आता रोजच्या रोज तुम्ही शुगरला कंट्रोल केली कारण शुगर एका प्रमाणाच्या वर गेली नाही तर तुम्हाला म्युकॉरचं हे होऊ शकत नाही. हे साधं गणित आपल्या सायन्सला माहितीये. एक महत्वाचं म्हणजे म्युकॉर हा आजार आम्हाला माहितीये, हा खूप वर्षांपासून याला कसा हँडल करायचा आम्हाला माहितीये. कोविड माहित नाही आपल्याला अजून पण म्युकॉर कसा फक्त त्याचं प्रमाण खूप जास्त आहे तो चॅलेंज आहे आणि मला 100 तरी मेसेजेस आहेत की साहेबांना सांगा की एम्फोट्रेसिन बी जे अँटी फंगल इंजेक्शन आहे ते बाबा मार्केटमधनं गायब होऊ नये त्याचा काळाबाजार होऊ नये यासाठी तुम्ही काहीतरी करा. सगळ्या डॉक्टरांची गळबळी निघाण आम्ही ऑपरेशन करू पण ते इंजेक्शनचा पूर्ण डोस नाही मिळाला तर पेशंट बरा होऊ शकत नाही.
परवाच्या कॅबिनेटमध्ये मुख्यमंत्री महोदयांनी तशा प्रकारचे निर्देश दिलेले आहेत.
अच्छा.
एम्फोट्रेसिन बी संदर्भामध्ये.
ओके. कारण सध्या आम्हाला प्रायव्हेट छोट्या छोट्या हॉस्पिटलमध्ये किंवा कुठे मिळत नाहीये आणि सगळे एकमेकांकडे भिका मागून बिचारे 2 तरी इंजेक्शन दे 4 तरी दे सध्या पेशंटसाठी.
म्हणजे आता ते रेमडेसिवीर सारखं झालंय पहिल्या सुरुवातीला
त्याच्यासारखं झालंय पण रेमडेसिवीर काय कदाचित काम करतं कदाचित नाही काम करतं हे एम्फोट्रेसिन काम करतच करतं. रेमडेसिवीर बगैर चालून गेलं एम्फोट्रेसिन बगैर चालणार नाही. हे एक थोडंसं आणि ते वेळेवर जायला पाहिजे ती खूप महत्वाचं आहे. सो थँक्यू आणि थोडा वेळ बघा आता सर्जरी सुरू करतो जसं मी तुम्हाला बोललो हा साला फंगस जातो कसा नाकातून डोळ्यामध्ये यासाठी मी सतीशला पहिली केस करायला सांगितली आहे. आणि श्रीकांत थँक्यू. मला आम्ही तुमच्याबद्दल चिकार बोलतोच आम्ही. सतीश मला नेहमी म्हणतो साला तुम थाने के लोग बहुत लकी है तुम्हारे पास मेन गॉडफादर तुम्हारा डॉक्टर का बाप ही है तो तुम लोग म्हटला ऐसा नहीं है. श्रीकांत ने भी मेरे को फोन किया था जेव्हा ते मध्ये पीपीच्या वेळी डॉक्टर लोक काहीच्या काही पैसे लावायचे 3000 रुपीज पर डे पर पेशंट. तर श्रीकांत कॉल्ड मी and he said this is not fair just because I am because he helps us at IMA at all levels. So he said we have to also reciprocate. Doctors have to show their caliber and character because if that gets destroyed then even Bhai, his father is called Bhai, he will not support you. So he's got a tremendous sense of fairness. Just because he's a doctor doesn't mean we in Thane are lucky and we can do with whatever. So I think his sense of justice, I was very impressed when on his own he said we have to behave in a certain way. ह्या याच्यामध्ये डॉक्टर्स cannot be governing profit.
आणि आम्हाला पण तुमचा अभिमान आहे की मुख्यमंत्री महोदयांनी तुम्हाला आठवण केली तुमची आणि म्हणाले ठाण्यामध्ये मुमकर आहेत आणि मग तुमचं आणि त्यांचं बोलणं झालं हे आमच्यासाठी खूप अभिमानची बाब आहे ना.
थँक्यू सर. आणि आम्ही काल कळव्याला जाऊन आलो. 2-4 दिवसामध्ये आपली ओटी तिथली तयार होणार.
Yes.
So we've already taken, sir has given instructions, Shrikant, yesterday, I think in a week's time, because the whole setup is ready. We have to just get the right equipment in the right place.
Great.
आणि will be, yeah. आणि सर आता हे सतीश जैन, नाशिम आणि मी आमच्या माध्यमातून आम्ही सर्जन्स लोकांना कॉन्स्टंटली इन अ वीक, वन्स अ वीक और इवन मोर, विल कीप कंडक्टिंग दिस सर्जिकल एक्सरसाइजेस. पूर्णपणे साफ होणं सायनस मधनं हे मूळ पहिली पाऊल आहे त्याचं. फर्स्ट स्टेप इज टू क्लिअर एव्हरीथिंग. तरच ते मागाचं अँफोट्रेसिन काम करणार. जर का फंगस साफ नाही केलं तर अँफोट्रेसिन कचऱ्याच्या बादलीत ओतून देण्यासारखं आहे. सो दिस इज वेअर आय थिंक द सर्जन्स फॉर्म अ स्मॉल स्टेप बट अन इम्पॉर्टंट फर्स्ट स्टेप. नंतर सगळं शशांक आणि राहुल यांच्या हातातच आहे. ऍक्च्युली किडनीचा एक पार्ट येतो वेअर द किडनी स्टार्ट्स टू गिव्ह ट्रबल बिकॉज ऑफ अँफोट्रेसिन. पण हे नंतर फिजिशियन आमचा छोटा. आणि सर लास्ट सांगतो, एनेस्थेटिस्ट लोक हे कोविड मधनं रिकव्हर होणाऱ्या माणसाचा लंग ऑलरेडी वीक असतो, त्यात त्याला अनेस्थेशिया द्यायचा म्हणजे सर्वात मोठा धोका. सो सर्वात मोठं हाय रिस्क इज अनेस्थेटिस्ट. आणि तिथे आम्हाला तुमची सपोर्ट लागेल की एखादा पेशंटला कॉम्प्लिकेशन आलं तर त्यांना असं नको वाटायला की कोविड मधनं मी बाहेर येत होतो आणि आता ऑपरेशन करून मला कॉम्प्लिकेशन आलं. सो इथे आपलं कम्युनिकेशन मध्ये विल हॅव टू बी लिटल प्रॉपर विथ द पेशंट.
प्रत्येक डॉक्टर आपला पेशंट बरा होऊन घरी जाण्यासाठीच प्रयत्न करत असतो.
अगदी अगदी. हा,
काही कॉम्प्लिकेशन होतात, दुर्दैवाने काही गोष्टी होतात.
थँक्यू सर. थँक्यू सो मच. या सो आम्ही सुरू करू सर.
हो, सुरू कर.
ओके सतीश. या सो शशांक and Rahul, do you want to say anything at this point?
No, I think congratulate you and keep doing your capacity building. Me आणि राहुल वर there with माननीय मुख्यमंत्री काहीतरी आणि मी I congratulate you आणि your whole ठाणा team आणि ऑल इंडिया टीम. हे जे तुम्ही कपॅसिटी बिल्डिंग करताय सगळ्या फॉर ऑल ओव्हर सर्जन.
क्या कह रहा है उसे इंजेक्शन के लिए बोल रहा होगा.
Trinity. It's unholy trinity of steroid, diabetes and mucor. And you need to break that trinity in a very appropriate way, and that's something which you are doing very well. But remember that these are all immunocompromised patients, and we know that COVID has, as you said, mucor you know everything, but COVID you don't know. But basically, people who have pre-existing diabetes, previous respiratory pathology, immunosuppressive therapy, hospital-acquired infections, and immune alterations, all of them lead to actually a lot of bacterial, viral, and fungal infections, and that include mucor. Of course, we should not forget aspergillum and penicillium in fungi. We should not forget HHV6 and HSV1 virus. We should not forget the other bacterial infections, including Enterococcus faecalis. And we all know that this alveolo-interstitial pathology is badly disturbed, including the CD8, CD4 cells in this whole guidance. And we know steroid has been one of the main causes of mucor. But we know mucor has a very high mortality. And mainly, as you said, the ethmoid sinus and the maxillary sinus and the orbits are the prime targets. And the invasive mucor is basically when there is diabetes, steroid, or a malignancy, or neutropenia, or a transplant, or a trauma. And that's something which we all know. But you need to ensure that, I feel that any patient who stays more than 21 days in the hospital should get a direct microscopy done of the nasal strap. And you should identify it, as a thing. But controlling diabetes for 3 months, as you said, or 100 days, using steroids appropriately, using clean and sterile water for humidifiers, and appropriate antifungals and antibiotics are important. And the do's and don'ts are very, very important. And otherwise, once a patient lands up with you with surgical debridement with antifungals, we should also try to make foscarnazole and ivaconazole also available, because you know that amphotericin B1 liposomal can be nephrotoxic. And we need to give a lot of adjuvant therapy. Only one question I had for all of you surgeons, that do you all use local amphotericin, because I was talking to doctors in Delhi, and the professor Arun Agrawal, who is a past dean of MAMC, he was saying that in those days, 20 years back, they used to actually do debridement of the tissue with local amphotericin. Are you all using that in Mumbai or in Thane? because we are very proud of you, Ashish, that when I think Rahul will now probably speak maybe 2-3 minutes, but we are very proud of you that you are doing this surgery, and people all over India are seeing. And apart from you, of course, Ashish is there, Dr. Sandesh Maker is there, and Dr. Satish Jain is there, and I think you all have a fantastic team, and you all are doing this so well. Rahul, you have anything else to say?
Two things, sir. Fantastic, and congratulations to you, Dr. Hashim and Dr. Jain, and of course, Shinde sir, namaskar, and Dr. Shrikant, namaskar. So, just two things I would like to say, that we should have the 100-day formula, which you said. In 100 days, try and eliminate mucor from COVID patients by having a good sugar control for 100 days, keeping the nasal cavity clean for 100 days, and essentially target and have 3 months where we can actually eliminate the mucor caused by this pandemic. And few steps, preventive steps, which will help us into reaching that is obviously glucose control. But the most important thing which I would like to say is that the humidified oxygen which we are giving, that water in the humidified oxygen needs to be a sterile water. There are actually, I'm just talking to a few people. I was speaking with Professor Anjan Ray this morning, and there are some additives in that which we can put in a distilled water, which are actually not allowing any organisms, microorganisms to grow in there. And maybe I might just come out with some solution where we could actually add that in the humidified oxygen, so that the humidified water which is there, even if it is not changed every day, for some reason, we may still not have an infective etiology. So these are some of the few things which we could do, and all the best. And we are very proud of you, Dr. Munkar, as Dr. Shashank said.
Our only request to us now that mucor is glaring at us, I think let's look at the microbiome. Please come out with some concrete things about that cocktail of antibiotics. We believe the first strike on the immune system is coming from, which we as surgeons believe perhaps are unnecessary, at least in the form that they are given and for the length that they are giving. And then, of course, COVID is doing something to the pancreas and the glucose metabolism. There's no denial. It's not just the steroid. Had it been just that, it was so simple. There's something going wrong where the heightened hyperglycemia is happening, and that is getting multiplied with the use of steroid. So I think these three components, if we can look at it, I think less than 100 days.
There is a
daily basis, if we can. Yeah.
Ashish, there is a fourth component.
Yeah.
The patient first come to a dentist. So
Yes.
the prevention start from a dentist if he gets a pain, because I know one of the listener is Dankers from Nagpur, who did about 25-30 cases, on cases. And he said the first complaint was a pain in the tooth. And then it started. So a dentist, a request to all the dentists, that if there's a pain and if there's a loose tooth, without any other problem, take an X-ray immediately and think of mucormycosis. As a dentist, we always see pink and white. Now the time has come to go beyond pink and white and think of this, so that it will be a combination of dentist to diagnose, maxillofacial oral surgeon, ENT, and then that's the way we can reach the brain. So if we can stop at the region of dentist and ENT, I don't think it can go to eye and the brain. So that's my prevention will start from us, because early diagnosis is the prevention. And every patient after COVID, as Shashank just mentioned, has to go for nasal. They have to go for dental treatment. And it's very easy to go every week to go for dental treatment and see if there's any tooth, any
just an examination for looking at discoloration. Yeah.
You know, Ashish, one more point I want to bring up is, as you very rightly said, we know a lot about mucor and we know almost nothing about COVID. But what is it in our minds? What we start thinking is that there is a tendency for COVID and mucor to coexist together. Now, why is that? Because both mucor and COVID cause endothelial damage.
Yes.
Basically, what happens is mucor has a tendency to bind with heat shock protein, which is GRP, glucose regulatory protein 78. And this attacks the blood vessels more easily due to the generalized inflammation created by the COVID, as well as the increased iron made available for the mucor to grow. Therefore, I also believe that in our treatment regimen, a little more attention has to be paid to anticoagulation. Long-term anticoagulation between 30 and 45 days to make sure, you know.
Mention specific. Go ahead, Ashim, you're on the right track.
Yeah. So to make sure that proper anticoagulation occurs using not just eco spray, lot of people have a tendency to give ecosprin. You start with enoxaparin, low molecular weight heparin, which is ideal. But then you immediately step down to ecosprin, but that is not good enough. What you don't want is anti-platelet aggregator. You want anti-factor 10A, which creates a coagulation profile. So in such cases, rivaroxaban, apixaban, and if the Honorable Chief Minister Sahib and Shinde Sahib and all with their good offices can bring down the cost of those drugs, help bring down the cost of those drugs, that will also go a long way to make sure, because you know that mucor occurs 2 to 3 weeks after the COVID. So what is that period? What happens in that period is also something we have to start thinking. And I believe that the vascular endothelial damage is what is creating this.
Contributing besides the high sugar and free iron,
So currently, Ashim, there is no data to show, unless the D-dimer or the ferritin is high, that we need to give anticoagulation. There's a complete consensus from the International Society for Hemopoietics and Coagulation. So
yes.
Recommended, but two things we must tell. In the current pandemic, why mucor has gone up? We are investigating this matter from the genomic science. The current strain, which is the second wave strain, particularly from Maharashtra, which is the 617.2 strain, causes syncytium in the olfactory epithelium. And therefore, this is more invasive and it creates a milieu in which there is a downregulation of ACE2 receptors, which actually lowers the immunity. And that is probably the reason that in this wave, compared to the last wave, we are seeing a larger proportion of mucor. It is a rapidly transmissible strain and also has a syncytium formation, which allows it to penetrate the nasal mucosa and then from there spread it over into the
Strangely, Shashank, none of these have any anosmia. Very strange.
No, but I'm talking about the invasiveness.
No, the
also, the lung involvement is a little more nasty with the current strain.
Yes.
And that is something which we have seen. So this is coming from the Institutional of Integrated Biological and Genomic Sciences from Faridabad, which is a CSIR initiative. And they are looking at this very, very closely. So there is very good published data. And yesterday also we were with colleagues in the US who are now looking at it very closely. Because by and large, mucor was not seen. It was seen in the last wave. It was not seen in the last wave. But the numbers this time have exponentially gone up. So there are only two possibilities. Either that our hygiene has been very poor, or we use too much of steroids, or there was, diabetes was there last time also, steroid was there last time also.
Yes.
So the only factor which is different is the strain is different.
The strain. I totally agree.
Agreed.
With the mucor, beyond just the water or the diabetes or the steroid. So that's the fourth component. So we need to be mindful of that. This time we are dealing with a difficult problem and a little more nasty problem. And that's why we need to be more cautious. But I agree with all of you all that I think Sandesh said a very vital point. Looking at the mouth, the dentist is the first window. Actually, the world's commonest disease is dental caries. And I think, we brush our teeth every day. So I think, this is something which is there. And Dr. Rahul will probably share his experience that yesterday suddenly he saw 16 patients. All of them had oral or nasal complaints and they all thought that there was mucor. This is the level of awareness at lay people. I don't know whether
awareness.
Oh, no. They don't even know the name. So Naveen kai azar hai te baga. They don't even know how to say the name. So Shashank, tell me, but this strategy of keeping the blood sugar on a daily basis under control, will that prevent mucor?
To a great extent, it may reduce the incidence of mucor, keeping the fasting below 110, postprandial below 140, 3 months average at 7%. It will reduce, but still you will need to do nasal and oral irrigation. And I think if you use a simple povidone iodine and innovative techniques to keep your mouth and nose clean, that's good enough if you ask me. Because I think that is the key. And COVID timetable now, as you said, is 100 days or 3 months or whatever you call it.
100 days, yeah.
3 weeks is acute vigilance and 3 months is chronic vigilance.
Yes.
So you should start that and we should promote that. Anyway, congratulations. And we must congratulate our minister, Eknath Shinde, and Dr. Shinde also has been very cooperative. And I'm happy that at Kalwa they have put up a plant there for mucor and a separate mucor ward. I think government of Maharashtra is also sensitive. But Ashish, we are very proud of you with your team, Dr. Jain, Ashim, and Dr. Mahekar.
I want to be on record to say about our Eknath Shinde ji, Sherdil Admi and Ekdam Dildar Admi. And he has action and speed which is unbeatable, and the scale at which he operates. The other day I had the chance to spend a lot of time with him, but the way he's doing, and it just comes from his heart and he gets implemented. Sir, खरोखरच सलाम. Absolutely. जे मी ऐकलं परवा तुम्ही सांगता की कुठे प्रॉब्लेम, ही इज अ सोल्युशन फाइंडर ऑफ अ डिफरंट लीग. कम्प्लिटली प्रॉब्लेमच्या समोर धरत नाही, पटकन सोल्युशन काढा आणि पुढे जा. ही वॉन्ट्स अ न्यू चॅलेंज एव्हरी टाइम. सो ग्रेट. थँक्यू सर, थँक्यू व्हेरी मच. म्हणूनच महाराष्ट्राची हे खूप चांगली चालली आहे, द वे वी आर मॅनेजिंग. थँक्यू. सो आता तुमची बरी असेल तर विल गो बॅक टू सर्जरी. सतीश?
Yes, Satish.
You want to make some comments about the medical this thing?
Okay, just to in brief, and sir is around, just update him what exactly the magnitude of the problem is.
शिंदे साहेब आणि श्रीकांत सतीशनी सायंटिफिक टॉक तयार केलाय, पण मेनली समजून घेण्यासाठी. आणि मग सतीश, वी हॅव टू शो देम सर्जरी प्लीज.
Okay, quickly.
Quickly, yeah.
Mucor is not a new problem. It has been happening from decades due to many immunosuppressive conditions. And these diabetes is the number one out of them, along with the use of corticosteroids makes it more and more, virulent and prevalent. There are a lot many conditions leading to mucormycosis. Out of them, diabetic is the commonest condition and has the best prognosis, because you can treat the underlying cause as compared to the other things where the treatment of the underlying cause is very difficult. And in this COVID-19 era, because of several ways, the COVID leads to immunosuppression. It targets the immunity, and that's why it is happening more in COVID-19 patients. There is a sudden surge in COVID-19 patients this year because of this immunosuppression caused by the virus, as well as the diabetic patients particularly were targeted by this mucor because they are immunocompromised, along with the liberal use of steroids. Sir was discussing just before why it was not so much in the first wave than in the second wave. Of course, the mutant virus is responsible for more immunosuppression, but in the second wave, the use of the steroid is more liberal as compared to the first wave. First wave, until it came to the peak, the steroids were not very extensively used. They were not known to be having good effect and not used very extensively. But now, steroid has been taken as a sanjeevani. Everybody is prescribing steroids from day one, and that is why contributing to this sudden surge of COVID cases, where the steroid has suppressed the immunity to that extent. And all these patients who were taking steroid were not advised to or not having had their glucose control, blood sugar control. So that is the major reason behind the sudden surge in this era, particularly in diabetic patients, because diabetes induces immunosuppression by various means. Most important is by means of impairing the neutrophilic function, which is the principal immunity of the body to combat the mucormycosis. And that is badly affected in diabetes. All sorts of activities of the phagocyte neutrophil is affected in diabetic patients, which is required at a high level to prevent this mucormycosis. And other than that, this tumor, this fungus has a tendency of angioinvasion, and which is facilitated in the hyperglycemic patients by this protein which is elevated in hyperglycemic condition, GRP, glucose regulator protein 78, which mediates invasion into the vascular endothelial cells, where this fungus multiplies, makes the thrombin plug, blocks the vessel, and gives coagulative necrosis. So this is further facilitated in the diabetic patients. That is another reason. And diabetic patient, particularly ketoacidosis patient, have this fungus as a enzyme ketone reductase, which enjoys the ketone as a fuel for the fungus to grow. So there are many reasons. Another reason, like Ashish, you were emphasizing last time, the iron. Hyperglycemia dissociates the iron from the iron binding proteins in the serum. There is no particularly free iron in the serum in a normal human being. In hyperglycemic condition, the serum iron increase is the single most important factor for the mucor to thrive. A successful mucor infection has to acquire iron from the host, and that is how this hyperglycemic condition facilitates the infestation by mucormycosis. So there are many ways. This condition is there's a sudden surge of cases in the recent era. COVID, diabetes, and then steroids, and that is a cautionary tale our physicians have to have regarding the use of steroid to avoid, particularly on the OPD basis, where the glycemic control is not possible. And secondly, only in severe cases under strict glycemic control according to the prescribed guidelines by the Indian authorities for a particular duration of time. If the steroids is used, they are not so harmful. So that is something we have to understand now to prevent future occurrence. See, this problem is not something which is not preventable. This is totally a preventable problem if we segregate certain high risk patients. Patients who are undergoing COVID-19 treatment, who are at high risk of developing mucor, you can see the listed ones, the regions. Patients having low lymphocytic counts have to keep an eye. Patient where the steroid had been initiated early in the course of disease. You know what is happening in this time of digital prescriptions, teleconsultations. The set prescriptions are being given to the patient, and patient, because of the panic, on day one they consult the physician doctor for the COVID, they turn positive, and the set prescription started without a glycemic control, and this is how this has happened. So that has to be taken care of. Patients who are admitted for COVID treatment having high interleukin level and ferritin levels have to be kept under observation even after discharge. See, all these high risk patients, why I mentioned these patients who have undergone COVID treatment, even after discharge from the hospital, should be warned of certain early symptoms of mucormycosis to catch the disease early in its course, to be kept under close observation by the treating physician even for a month or two for the strict glycemic control, which can lead to mucormycosis. This infection is seen even after a month or so after the recovery from the COVID infection. So this immunity, the lasting immunodeficiency is the principal cause behind it. And these are the patients who are likelihood to develop mucormycosis, and these should be kept under close observation to prevent this dreaded disease. So this is a preventable disease. The efforts have to come from both sides, from the doctor side, from the patient side, to follow judicially and not to take over-the-counter drugs. Now, variety of over-the-counter drugs are available, for the COVID treatment. And in the last, I mentioned about the antibiotics. Everybody having infection, look for the antibiotic. Antibiotics depresses the immunity, the broad spectrum antibiotics particularly, by means of suppressing the normal commensals, which are useful, which maintains our human microbiome, which maintains our overall immune system. So the overall immune system is maintained by the good bacteria's commensal, which is suppressed or inhibited by the broad spectrum antibiotics. And particularly in the COVID situation, the use of broad spectrum antibiotics should be more and more discouraged. All these factors all together are contributing to the immunodeficiency where the mucor is infecting. It's not mucor is coming from anywhere else. It is in the ubiquitous in the air. It is our commensal, and it can invade only when the immunosuppression happens to occur. There are a variety of mucor, family, the big family class of zygomycetes, which is divided into mucorales, antiphorales, and jucophorales. And out of them, mucorales are responsible for this infection. And out of them, Rhizopus oryza is the single most important. Why I'm saying this? It's the next order. Because all mucormycosis patients do not behave same way. Some have deep infiltration into the bone, some have superficial, some present early in the course with a blindness, some even after a month do not present with blindness. There is a difference, and that's how there is a call for species and generic distribution by means of culture and other studies, the cell culture and the genetic studies, so that we can divide classify the particular class responsible for the infection, so that we can prognosticate those patients in a much better way. So this is important, and this is not available in the routine clinical setting, and this is the call for the next order, which can facilitate our treatment and the prognosis in a big way. So early symptoms, this is for the government now. This is for the media now, for us people, we people now, to encourage, to spread this awareness to all these COVID-19 recovered patients to warn of early symptoms of mucormycosis, which is the best stage. The first stage is nasal stage, where if it is picked up, can be treated in the earliest way, and the success rate is almost up to 100% if treated in the early phase. So all these, any of the symptoms, if a COVID recovered patient is developing, must consult an ENT surgeon to pick up this situation earliest in the course of disease, which is the best time to treat this problem. So all those high risk recovered patients from the COVID, it is duty of we doctors to tell them, warn them with early symptoms. If they happen to develop, must present earliest to prevent this dreaded disease to spread to the orbit and the brain further. So this is, as far as the diagnosis is concerned, we discussed the MRI, contrast MRI in detail to see the extent of the disease as well as diagnosis. Nasal endoscopy is the simplest way. You put your endoscope and you find the black star or the excessive crusting in the nose. Excessive crusting in the nose is the earliest sign of mucormycosis. Any diabetic patient, by and large, coming to you with excessive crusting in the nose, you can assume as a mucormycosis until proved otherwise. Because this is because of the lack of blood supply in the underlying mucosa, allowing it to more and more crusting. This is something very, very important. Numbness around the nose, teeth, cheek is a sign of V2 involvement. Any patient showing numbness, V2 comes to the pterygobaltine foci, you can assume that the pterygobaltine foci is involved. So there are certain clinical signs which points us the spread of disease, which can, your eyes see what your brain knows. So we need to keep everything in your mind to gauge the extent of the disease to tackle this problem. Then the frozen section, all know there are a lot of questions last time that how do we diagnose? How do we diagnose? Can we start the therapy early? You can start the therapy, but why to waste time in diagnosis? Your frozen section can give you a report in 30 minutes. A conclusive report of frozen section is more than 98% sensitive for the mucormycosis, which clearly depicts this broad accepted right angle branching fungi as mucor. So in any case of doubt, it is better to take a biopsy, frozen section, and start the treatment, which doesn't take long, more than 30 minutes, rather than instituting an antifungal therapy. There are a lot of reports, questions coming from people to start voriconazole as a preventing measure. Fungal infection in ICUs, in long intubated patient, ventilating patient, and all those who stay in the ICU for long to start voriconazole as an antifungal. This is dreaded. This is criminal. If you start voriconazole, it can make your mucor infection, if it is mucor there existing, more virulent. So rather than instituting hit and trial, we must have a tissue diagnosis to start particular therapy for the mucor where the voriconazole has no role, rather than to worsen the condition. And for the diagnosis, by and large, no blood test is available. This should be very, very clear. A lot of people are going for the blood test like beta-2-glucan, galactomannan. There is no galactomannan, beta-2-glucan in the mucor cell wall. It is found in the aspergillus cell wall. You can detect aspergillosis by blood test to a certain extent, but not the mucor. KOH mount is the early test you can get in 30 minutes, but better to take a biopsy and get a frozen section to make the picture very, very clear. So this diagnosis is very important for everybody. Early diagnosis can save the patient's vision as well as the patient itself. Antifungal, like nowadays, like we requested, sir, just now about the availability of this medication, amphotericin B.
Sorry.
It is available in 5 forms. All forms are available except liposomal. Liposomal is the form where is this amphotericin is sandwiched between 2 lipid layers, which has the highest penetrance to the fungal wall, which is lipid structure, and that way it becomes 20 times more, effective than other brands of the other formulations of the amphotericin as far as the tissue concentration is concerned. 20-fold more active. It is as lethal to the mucor as lethal the mucor is to the human being. So amphotericin liposomal is the drug of choice, but unfortunately it is out of stock, available nowhere in the country. And in a and I tell you, in our state, our chief minister is trying hard. All big bureaucrats and everybody is trying hard to procure this from central government, from here and there. Companies importing from other countries, and everything is going on. So this is the need of the time. Yes.
Yeah, it should be available in countries they are not seeing mucor. I think it will be easy to import it. Yeah.
Yeah. See, the problems is multifold. The reason is the companies who are manufacturing liposomal had never manufactured to this scale.
That scale, yeah.
Their manufacturing capacity was not of that scale with the requirement right now. And secondly, it is not very common infection in developed countries. So even the developed countries are not manufacturing it at a very large scale. So problem is both from the companies in India and the companies abroad to manufacture it at the large scale, which is the need of the time. It is life-saving drug, but still, I am sure that all governments are trying hard to procure this to save lives of so many people. But until then, the other options are these other forms, which are also effective, not as effective as liposomal. On the other hand, they are more toxic to the patient relatively, renal toxic, and more than that, they have more episodes of hypersensitivity, lethal hypersensitivity reactions with other brands. So we have to be very careful. We have to dilute them completely, institute under cover of the anti-hypersensitivity injections and all. We have to be very, very alert about when we institute the other forms. Isobuconazole is a good alternative for, particularly it is renal sparing effect, but it is not as potent as amphotericin B, but it is a good alternative and can be instituted. It is available in the tablet form as well. Cost is a limiting factor, almost 3 times than amphotericin. But in this era, when the liposomal is not available, this is a reasonably good alternative. Along with other antifungal, posaconazole, you can give in combination. The cost, again, using these two together is very high. For in a country like ours, it is very difficult for the patient to use isoconazole and posaconazole together every day, which costs almost 50,000 a day for the patient if you take together. So this is something a limiting factor in this. So the need of the time is to make sure the availability of the liposomal. We are looking forward to it in the coming times to relieve from this great disaster going on. Role of surgery we have discussed several times.
Can you hear me?
Yes, yes.
Yeah, because the Mantri ji is here. I think thoda gadbad hone wala ye posaconazole as a preventive drug. वो भी वापस बहुत people will start taking it indiscriminately.
Yeah, that should not be used because it can lead to resistance.
It is not like the drug of choice कि वो तुम लिया तो fungus नहीं होने वाला है, mucor नहीं होने वाला है.
It's not like that.
Not like that, yeah.
Yeah. It can even
let it be only doctor का, नहीं तो धड़ाधड़ लोग वो खाने को शुरू करेंगे.
Yes. So, but this posaconazole has been advocated for prophylaxis by the recent European guidelines in certain category, high-risk patients or, in ICU, on ventilators, long-term ICU admission, likely to develop fungal infection, neutropenic patient, diabetic, ketoacidotic patients as a prophylaxis. Because it is available now in the injection form as well.
Own set of side effects, no? So it should not be taken liberally.
Yes. So do we go ahead with the case or you want me to carry on?
Hello? Satish, surgery shuru karo.
Okay.
Yeah. Subhash, सर एक 5 मिनिटात सर्जरी सुरू करतो. तोपर्यंत मी थोडीशा मेरा स्क्रीन शेअर करो दिनेश. I'll just show 3-4 slides in my style of doing it. सर मिलिंदचा फोन आला आता. तो म्हणतो एक 10 मिनिटांमध्ये कळवतोय सीएम सर जॉईन होत आहेत का काय.
ठीक आहे.
हे
चालेल.
हे मी एक 2-4 स्लाइड दाखवतो. झालं स्क्रीन शेअरिंग. या हे सरांच्या बद्दल, शिंदे साहेबांच्या बद्दलचं मी छोटंसं हे केलं होतं. आमचे भाई म्हणतो आम्ही त्यांना ठाण्या. इन थाने वी कॉल हिम इन मराठी वाला भाई, मतलब एल्डर ब्रदर. आई सेड इज शेरदिल एंड दिलदार आदमी. वर्ड इज वेरी इंक्लूसिव. You know, इसके पास लोग they get attracted to him and they remain because he treats everybody equal. He's not like the big guy and you guys the small. Very, very inclusive in his entire energy. I mentioned about the speed of thought, action, emotion, and scale. And like I said, Satish tells me, तुम्हारे पास साला lucky है, तुम डॉक्टर का बाप है. The first comprehensive infrastructure is getting established in less than a week in Thane. Just 2 days back, he has given clear instructions. Whatever it takes, do it. Aditya ji, I don't know much. Shrikant has just called to say there's some building has fallen in Ulhasnagar. It's his constituency, so he's gone there. I will just show some. I had prepared a very simplified version of this, but we need a Superman. Is Shashank there? We need a Superman now to prevent the mucor. And the Superman here, what's the face? This is the Sugarman, the Superman, Sugarman, Shashank Joshi. The metaphoric, all the diabetologists, if Shashank and the physicians can prevent the sugar from rising, if they can prevent the blood turning into sugar syrup on a daily basis, due to COVID and drugs, the war on mucor can be won. This is the human being is becoming a sack of sugar in this COVID and the steroid era. We have to respect the microbiome. From our side, Shinde sir, आमच्या साइडने आम्ही वॉरियर कमांडोज तयार करणार आहे, म्युकॉर सर्जिकल कमांडोज, वेर सतीशच्या अंडर्स अशी मी आणि असे 100 तरी महाराष्ट्रात आणि अख्ख्या इंडियाभर वी आर गोइंग टू क्रिएट, who will do an absolute thorough job. There are more and more. This is Satish Jain, this is Ashim, and this is me. And असे hundreds of such commandos who will do a thorough job, and on a bi-weekly basis or we'll conduct such surgical training programs and make sure we win this war against mucor. We also have specialists like the magicians, like the Harry Potter, who's magic. So we have friends like Sandesh Mayekar doing a great job. Besides now in mucor, of course, the teeth. Here he is flying on a toothbrush like Harry Potter flies on the broom. And last but not the least, the anesthesia people. We need a good MR radiologist team, and we need the best of anesthesia people will be required to give anesthesia to these COVID people. We need them. And from sir, what we need from the government is credible communication center.
Hello?
We don't want panic. We want, Shashank, you're there?
Hello? Bola mic nahi aa raha.
So credible communication center to prevent panic. And we need amphotericin B, amphotericin B, amphotericin B. With this, sir, आम्ही सांगतो, we will win the mucor war before you even expect it. So this is our promise. Thank you so much. So,
thank you, Ashish. Can you hear me?
Yes, I can hear you. Now we can go to your surgical.
Picture. Yeah, Ashish, I am with the endoscopic picture.
So this is Nakachat, sir. With the telescope, he's looking inside. And you see that black thing, they point it out. Sir, Bhaktayat, India sir is watching.
Sir, can you hear me?
Yes, we can hear you well.
So, Ashish, this is the primary picture after decongestion on the left side.
Yes.
On the same patient, you have just gone through the scan, where the patient which will require orbital clearance.
So, इथे सर एक खपली बनते, म्हणून आम्ही त्याला लपलेली खपली म्हणतो. ही जी काळी एरिया आहे, दिस इज द एरिया वेअर द पहिली खपली बनते, तर ती टेलिस्कोप टाकल्याशिवाय दिसत नाही.
See, you put your endoscope in the mucor patients and you will find this picture as the commonest one. Affecting the middle turbinate, first of all.
Yes.
See this, the blackening of the turbinate. And now one more thing, at this point of time, I would like to mention, the reason for the need of revision surgery is simply the overlooking of certain areas during primary surgery. Now see, one of the common area we have seen, we have lot many revision cases we have got, and see this, see the posterior part of the septum.
Yes.
Can you observe the blackening of the septum?
Yes.
Involvement of the septum. This is already invaded with the mucor, and this needs to be thoroughly debrided, otherwise If you leave behind, there is no fun in operating upon such case.
Did
So
the MRI also tell you this involvement of the septum?
Yes, it
did?
is not uncommon. The posterior part of the septum is commonly involved, and one must keep an eye on the MRI, on the endoscopic picture. See, this surface blackening shows the inside septal cartilage bone is already necrosed and need to be removed. Okay.
Yeah.
Now, the second thing about, as I mentioned, not only for the surgical access, but the post-operative surveillance and the medication and for other purpose without the need of radiology is the access given by the Dankers approach. Modified Dankers approach, which was proposed earlier by Sternman and Canfield. And there's a simple approach by means of we remove the medial wall and a variable part of the anterolateral part of the maxilla to go head on to the posterior part of the maxilla and behind that. So this is a very good parallel highway to the paramedian skull base where the mucor is frequently invading. So in order to do this mucor, modified Danker, there are certain steps we have seen several times, couple of times in the last year in many of the webinars we conducted. And the last week as well, you saw almost 5 Dankers. See, the simple philosophy behind this modified Dankers is the perfect entry into the maxilla, prevention of, epiphora by means of proper handling of the nasolacrimal duct, and preserving the orbital floor so that you can go along the orbital floor till the posterior wall of the maxilla intact, and you cut the nasolacrimal duct there and have a full view of the maxilla behind. So how to enter into it? First level, this is the level of the, the axilla here. The axillary level is here.
Yeah.
So I will go a centimeter below. The reason is I don't want to enter into the orbit at the beginning. So you have to step below the orbit. So roughly, this is roughly, see this? Coming anteriorly to the pyriform aperture. Be careful not to go more anterior to it into the alar cartilage, otherwise may lead to a deformity. And see the tool, coagulator, the tool for all this, the single magic wand, which has a cutting ability, coagulation ability, has a suction, irrigation, everything. And see where exactly.
एक मिनिट सतीश, हे जे इन्स्ट्रुमेंट आहे हे फार महत्वाचं या ऑपरेशनसाठी. याला कोबलेटर म्हणतात. साधारण 5-5.5 लाख रुपयाला येतं हे असलं तर सर्जरी खूप चांगली आणि एकदम प्रिसाइज होऊ शकते. ब्लडला ते
दिस इज माय पायरिफॉर्म अपर्चर.
कोबलेटर म्हणतात.
See the maxillary bone, the anterior end of the maxilla.
Yes, can see very nicely. Yeah.
This is the inferior turbinate, which is a separate bone. See here.
Yes.
It's a separate bone, which you can dislodge from here easily. You can out fracture and remove it easily. See, the beauty of the coagulator is it maintains visualization. It gives irrigation, suction, everything at the same time. Now, this is the anterior wall of the maxilla. Now, in order to go further behind, I would like to go to the anterolateral wall. See this?
Yes.
It's staying subperiosteally. See this? Section periosteum.
Very nice. Yeah.
See this? What I'm doing? See the small nerves which are being severed is the anterior superior alveolar nerve. I am on the anterolateral wall of the maxilla. Depending upon the need, I can go further, more and more, remove the anterolateral wall, right up to the infraorbital nerve. Here in this case, I don't think I need to go that further, so I am not going there. See this exposure of the anterolateral wall, complete exposure.
Beautiful.
I'm sure so far everything is clear.
Yes, very clear, Satish. Yeah.
How's the picture, Ashish?
Very nice.
Super.
See this anterior thin bone you can remove by means of your punch, by means of your lux forceps, whatever. Now, I can remove this bone quickly by means of a chisel and hammer. To be more precise, you can use your micro drill, and this is my tool. My favorite tool, this stylus from the Medtronic, and the stylus now has changed to, we have bought the new one, the new edition, MR8. MR8 is new edition, more powerful than stylus. And see, this is a coarse diamond burr.
Yes. So the
See
bone
this?
bleed, yeah.
I am running on the anterolateral wall to enter into the maxilla,
Yeah.
just to enter into it, widen to it, to look into the maxilla.
Yes.
Yes.
For that, I don't breach the roof to enter into the orbit so early. See this? See, it cuts the bone like butter. This is coarse diamond. It is not cutting burr. This is 70,000 RPM I am using.
Oh, okay.
See, cuts like butter. And the beauty of the drill is, it is so sleek. I'm using it like a pen.
It's also 15-degree angle.
Yeah, 15-degree angle, so your shaft doesn't come in the view. Now see inside the maxilla. See this prominence of the nasolacrimal duct?
Yes.
There's the prominence of the nasolacrimal duct,
Yes.
and that's the level of the orbital floor. This is important to ascertain at this point of time, so that you don't enter into the orbit accidentally. Now I can further lower it. If you need, you can lower it, widen it. Laterally, you can thin out so that you can punch it easily. Yeah.
The anterior most bony hump is very important to flush it down, because it acts as otherwise as an obstacle to your future.
Yes. The soft tissue may start falling. What you can do, you can cobble it to stiffen it. See this?
Fibrosis to make it stiffer.
Yeah. So it should not fall down. Now the things are very clear inside the maxilla, and now what I am going to do is simply I can punch it out, this thin bone, until the nasolacrimal duct. See the nasolacrimal duct coming in the picture?
Yeah.
Again, drill. See the nasolacrimal duct that needs to be properly handled to prevent, epiphora in the future. Flush with the orbital floor. That is the best way to prevent epiphora, when you cut it flush to the orbital floor, because that way it is not going to be hanging freely in the nasal cavity to acquire fibrosis. See, I am drilling the nasolacrimal duct from all around. Yeah, you can see now much better. See this thin bone?
Yep.
So this is the part of the exposure. We have seen we have to deal with the orbit, we have to go behind the maxilla. This exposure is the key. Compromising with the exposure is something, compromising with the overall outcome. Punch. Yeah.
The way to prevent nasolacrimal duct stenosis is to cut absolutely flush with the floor of the orbit.
Yes, that is the aim. That's why we expose the bone anteriorly, flush to the floor of the orbit, and you can see there behind as well.
Yes, you can see literally the sac coming into view.
Yes.
Yeah.
And this is the point where this needs to be severed. Scissors. Hold it tightly. Okay.
Cut sharp, right at the roof.
That's a very important point you raised. Cut sharp to prevent fibrosis. Clean cut edges to prevent fibrosis. And this is the nasolacrimal duct. Now you can see thoroughly. That's the floor of the orbit you can see.
Yes. You're using 40 degrees?
40, 40.
40, yeah.
Red 40. This is lateral wall of the nose. And this is the insertion of the turbinate, inferior turbinate. Inferior turbinate has its vascularity from behind.
Yes.
Yeah.
So again today we have started from the basic case and we'll be moving further with more advanced cases. The next is a much more advanced, and then a case will require almost a complete radical maxillectomy with skin removal and everything with free flap.
That's the one with the skin involvement, no?
Yes, palatal involvement. This mucor has an affinity for the maxilla and the sphenoid bone, particularly. It can involve other bones as well, but these two are the areas which it commonly, involves.
Is there something to do with the sphenopalatine the distribution?
I don't think, because the other areas also are affected. It's not limited to the sphenopalatine distribution only. See the kind of exposure now we'll be having. And that is the key. Now we can deal with any critical areas, involvement of the skull base, anywhere in the skull base. This is like a highway. Find out. This.
Shinde sir was a PWD minister earlier. Highway sir, highway.
समृद्धी हायवे
झालं.
Yeah. Now divider.
नागपूर हायवे करतोय ना आपण.
भरपूर आहे.
See, this is the turbinate which I am going to take for the histopathology. Now we come to see this.
Yes, it's just so fragile.
There is no vascularity.
No vascularity.
See the necrous tissue. See that? See the necrosis behind.
अभी सर को फ्लोर ऑफ द ऑर्बिट दिखाओ.
Yes, yes. See the floor of the orbit.
इथे सर डोळा आहे, जिथे त्याचा आता इन्स्ट्रुमेंट आहे ना, ते डोळ्याचा फ्लोर आहे. तिथून ते आणि हा बोन चांगला जरी दिसतोय, हा एकदम हेल्दी दिसतोय हा बोन. सीटी स्कॅन वर वी वुड हॅव मेड अ मिस्टेक की हा बोन चांगला आहे म्हणजे मागे आजार नाही. तो थोडासा एक 10 मिनिटात तो उघडेल त्याला आणि आपल्याला आजार दिसेल.
So this one is the part of the turbinate we have removed. We saw the disease in the
Necrosis.
this area completely, the posterior wall of the septum, the ethmoids. See, everything is looking involved.
Yes.
So this way, first we'll debride all this to get to the medial wall of the orbit, and that you can do quickly here. As we all know, the orbit is already involved. See this?
Yeah.
Yes. How often do you see involvement of the cribriform plate also, Satish?
Not uncommon. We have seen in all extensive cases commonly.
How do you reconstruct that?
Be careful not to breach the dura. You can thin out a little bit, but we try, avoiding complete removal of it to invite further problem. But it's a thin bone, it's not that. See this?
Yeah.
Complete mucor. See this? Complete necrosis.
Complete.
हा सगळा म्युकॉरनी डेड केलेला टिश्यू आहे सर.
Yes, all that.
दिसतंय ना, त्याच्यात रक्तपुरवठाच नाहीये. तो म्युकॉरनी रक्तपुरवठा बंद करून टाकलाय त्याचा.
See, Ashish, what I was saying?
पोचूच शकत नाही. हे काढल्याशिवाय एफोड्रेसिन बी कॅनॉट रीच.
Yeah.
This part of the septum, what I said.
Totally negative.
This area of the septum, I call it invaded because why it is happening so? Because the underlying septum bone is completely necrosed. Can you see?
Yes, very nicely.
You can pick up so easily by means of the color of the septal mucosa that what is happening to the underlying septum. And this is something which is most frequently overlooked.
Yes.
We have seen in many, revision cases, we got this part of the septum not removed, completely necrosed. And surprising, this is most accessible area, yet not addressed.
So we don't think of septum as the location for the mucor.
Yeah. So what I will do before go to the orbit, clearly, I will remove this posterior part of the septum, which is not looking healthy to give me more space.
Yeah. And you can come in from
again your magic wand.
So you are judging only visually where you will take your incision in the
in the normal looking septum.
Right. So it's basically a posterior septectomy.
See my incision at the normal looking septum level.
Yeah.
Dinesh, how many people have logged in?
See this. See now, this part of the septum, see the difference from this part of the septum. Can you make out?
Right.
And once I remove this, my access would be much better. See on the opposite side. On MRI, it was absolutely fine, but see the septum, the kind of septum it is completely rotten. Can you see?
Yes.
So this thing, if you overlook, is something, a disaster. See the septum.
And see, it would have been totally normal looking on CT scan.
Yes. CT scan, everything just opacified.
Yeah.
That's it.
That's it.
You cannot differentiate why it is opacified. And I will show the eye after this. You have seen on the MRI.
Yeah.
Let's see. On endoscope. See now, the picture is clear. Yeah. Going to the opposite side, the brighter. That's the remaining septum above. Looking good. See, normal looking areas you can leave. The bleeding areas you can leave. Now I'm opening up this anterior part of the roof. See the kind of exposure we have now. See this, all this bad mucosa, bad bone. You have to be little radical in debridement, so that you don't have to come back.
Now you don't have highway, you have expressway.
See now, this is the posterior part of the septum, and this is what I'm removing now. And see, this is the necrosed septum.
Yeah.
I hope so far everything is clear.
Super. Excellent. Are you going to be removing the sphenoid rostrum?
Yes, sir, 100%. When that's a very important point you raised. Once the posterior part of the septum is involved,
Yeah.
must remove the rostrum and open the sphenoid sinus bilaterally. And sphenoid you have seen was a lot of collection.
There's debris in the sphenoid also.
Yeah.
Yes. See, this would be my access to the orbit. Once I remove this area, would be my access to the orbit.
Yeah.
See this periosteum.
Yeah, yeah.
Totally.
I will show you later. Yes. See, you have to be able to predict the spread by clinical means, by radiological means, and the exposure is the key.
Satish, how many days post-COVID did this patient present?
We have got patients after 10 days, 15 days, 20 days, even more than after a month we have seen.
So typically cutoff is 1 month?
6 weeks.
Not really, even beyond 1 month we have seen.
Okay.
So there is no clear-cut way to say cutoff. There are a lot of things unanswered.
That I think later it's going down.
Lot of things unanswered because of lack of species and general distribution of the mucor by culture studies and other genetic studies.
सतीश तेरा क्या मत है ये सब बोलते हैं ऑक्सीजन ट्यूबिंग एंड वाटर व्हाट डू यू थिंक अबाउट दैट
See, simply it cannot, be related in the present context because that oxygen tubing and all is same for all patients.
for all so many years not
For
just
so many
Yes, yes.
We have had thousands of diabetics on this.
Why particularly diabetics and steroid taking patients are affected?
and the same tubing and the same oxygen इतने सालों से वही चल रहा है
Yes, yes. See, there are so many things to relate. That is definitely a point of discussion, but there is no evidence.
Agreed. But of course, the
See,
other
see
way is
what-
to say that,
See about the rostrum.
yes.
भी जरा हाँ
See the rostrum. See the sphenoid, opposite sphenoid. Just to show you the opposite sphenoid. See this?
Yep.
The rostrum, intersinus septa, sphenoid, this, and this periorbital. Now let me clean all this quickly to enter into the orbit now.
please do that because our listeners are waiting there means thousands of crores of files are there एक घंटे के ऊपर टाइम दिया उन्होंने आपको
We are grateful to him for sparing his valuable time.
हाँ भाई किती फाईली राहिल्या मोठे मोठे बिल्डर थांबले असतील म्हणजे साहेब काय ऑपरेशन बघत बसले
हे महत्वाचं आहे
See the sphenoid, see the ethmoids. See the ethmoids,
yes
all necros.
हा सायनस आणि डोळ्याच्या मधला बोन आहे त्याला काढलाय त्यांनी आणि आता डोळ्याकडे चालला
Not doing an adequate debridement and treating with antifungal is something never works.
Yeah, it's unnecessarily increasing the duration of the fungus treatment, antifungal treatment.
Yes, yes.
It's
And
loading the patient.
And yes, antifungals are not going to penetrate.
Yeah.
there are
Sorry, Ashish, काय म्हणत होता?
40 days of antifungal
Yeah, I have seen patients. See this?
Oh my God, look at that.
This is all dead tissue. This sphenoid.
So
See
would
the-
we be drilling the
see-
area of the cella and all that or no?
See the optic now.
yeah.
This is optic nerve, carotid artery, opticocarotid recess,
Yeah.
interior of the sphenoid. I will easily easily take away the rostrum now.
The optic now.
See this rostrum?
Yeah.
Divided. See the sphenoid above the posterior. Oh, sorry. In 5 minutes, we'll be in the orbit.
जरा उधर वॉश करके ऑप्टिक नाउ दिखा. Let me show it to.
Yes, Ashish, just a minute. Don't think twice to remove any bad looking mucosa.
Or even on the opposite side, doesn't matter. Yeah.
Yeah.
How often does it get bilateral?
Very common. See the cella in the middle?
Yeah.
Intersinus septum.
Yeah.
Wash. Yeah. Yes. So now for your orientation, you can see the skull base, complete exposure of the sphenoidal skull base, opposite side. Wherever the normal looking mucosa, we are not supposed to do anything. Section.
Side of that.
Yes. Now, wash karna. मेरे को दे wash. Section. Yes. Now this patient is blind in the left eye. Look at the condition of the eye. Edematous with ophthalmoplegia.
Totally fixed.
Totally. Give fast the debrider. Now just finishing the ethmoidectomy to reach to the area of interest, that is orbit.
Wash करो field को, surgical field wash.
And all. See now the skull base, ethmoidal skull base.
Yes.
And now I'm moving toward the orbit.
Yes.
Give me.
Field clean करके दिखाना sir को देखना.
Yes. Give me 70 degree. So now I am going to enter into the eye. Non-functioning eye, a depot of necrotic tissue, dead material, fungus, everything.
Satish, how often did you see sympathetic ophthalmitis?
Not very often in this condition.
Right.
Now with a 70-degree, can you see a much better picture?
Yeah.
Focusing on the eyeball. That's the medial wall I'm removing.
आता now he's डोळ्यात चाललाय, he's going into the eye. डोळ्याच्या वरचं थिक कव्हरिंग आहे, त्याच्यावरचं बोन काढलाय, now he's packing material. The clarity is not there, Satish.
Yes.
Yes, now it's nice. Thank you. Yeah.
See, I'm removing this medial wall.
Yeah.
And what you see inside now is the necrotic tissue. Now see.
Yes.
Can you see inside the necrosis?
Yes. Complete necrosis.
See this?
Yes, very nice.
All dead tissue.
Fungus. Everything fungus.
See, this is the muscle here.
Yes.
My goal is not orbital exentration. My goal is exentration of the necrotic tissue. You have to be very clear about it. Not to use a fixed terminology for this region. See this completely.
Yeah, it's not bleeding also. You're like debriding.
See this completely necrotic tissue in the orbit. Yeah. Okay. But done.
But at the same time, the muscle appears okay.
Yes. See behind.
Oh my God.
Even in the pterygoids, I think it spares the muscle for some reason. Yeah.
Yeah. See this behind. All necrotic tissue.
Yes, we can see. This is garbage clearance.
Yeah, this is all garbage. See what happened to the eye. Everything. All garbage. So by MRI only we could pick up what exactly this could be 60. If we leave this
cases where there is the vision is still normal and we see invasion into the eye.
Yes. So vision is still normal. Invasion into the eye means the disease is still far off from the optic nerve to induce inflammation. So you have to be very, very careful. Remove that necrotic region, sparing the optic nerve if you can, because it clearly indicates that the optic nerve is still spared from inflammation. That means disease is not very close to optic nerve. You can open the orbit, clear it, preserving the vision.
And you have to, of course, then preserve the muscles. You have to be very careful with the muscles.
Yes.
There's a problem of sometimes diplopia and all that occurs, right?
Diplopia is bound to happen.
Yeah.
As you open the orbit and debride something as the axis changes.
Correct.
See the muscle behind what I'm removing? Necrotic tissue. 40.
Going now behind the globe, you're already medial compartment is.
If I leave even a trace of necrotic tissue, problem may again come back. Orbit is a direct avenue, a gateway to the brain. Orbital apex is just anterior continuation of the cavernous sinus. Look now.
What do you do when there's proven cavernous sinus thrombosis along with it?
You can't be very, radical in the cavernous sinus.
Exactly.
Because of the neurovascular structure.
Internal carotid artery and so on and so forth.
Yeah, so you can't do anything to it but to hope for the recovery later on with the anticoagulants, with the, antifungals and all that, but practically you cannot do anything radical into it. Still, there is disease in the orbit, which I am looking at. Yes, the brighter. See, this is called orbital clearance. See the disease behind?
Very nicely seen. Yes, Satish.
This is all necros.
Yeah, you can compress the globe and go beyond it. Now, where is the optic nerve?
Yes, we'll show you. See this. I am going behind. I don't know what to remove, what not to, what it is. The structure which is necros need to go. As simple as that.
It's necessary to do that to save the life.
Yes, that's the optic nerve.
Yes, now we can see it very nicely.
See this anterior muscles I am preserving. Can you see with my shaft of my blade?
Yeah.
Region that those are not involved.
Yeah. You're compressing with the shaft and protecting them.
Yes. This is not malignancy. This is something infection where the necrotic tissue need to be removed for the better penetration of the
With the cosmetic deformity.
of the drug. See now inside the entire orbit.
Yes.
What you need to leave at the end of the surgery, the healthy orbit. Can you see?
Yes.
This is the globe you can see. Can you?
This is the globe. This is the main dola.
Yes. This is all anterior muscles, floor, everything. Very clear?
Yeah.
And absolutely healthy orbit now from inside. No need to unnecessarily debride the healthy tissue. Once you have removed this necrotic area, necrotic tissue.
Shashank had asked a question about topical amphotericin.
Yes, there are a lot of publications, a lot of people are using. We are also using as an adjuvant that it should work. There's no harm in doing that, I would say, but I have no data to support it strongly that it works or not. What you can do, your simple deoxychelate amphotericin costing 300 rupees.
Yeah.
You can use for topical purpose. See this.
In the current scarcity time, I don't
This is with the see this orbital, debridement was done with a 70-degree telescope and 60-degree blade.
Yeah.
And see the entry into the orbit behind the eyeball. This is the retroorbital tissue which is involved, not the eyeball. Why to unnecessarily sacrifice and do unnecessarily orbital exenteration?
Yes.
This we have done in hundreds of patients with excellent results.
Sir, when you'll take call on enucleation?
Pardon?
Almost never.
Enucleation.
That's what he's saying. Almost.
Rarely required. See, in this continuity, if I find everything necrotic, I'll keep on removing. My goal is very, very clear to remove the necrotic tissue, not everything by structure. See now, everything clear? Our skull base, the upper part of the septum.
So it's a radical removal of the necrotic tissue and not radical removal of the structure.
Yes, exactly. See this, the opposite middle turbinate, everything, and now I'll change to 0 degree. Now still I have area left to look into as the patient is blind. I told you last time with the intact posterior wall of the maxilla with disease behind.
Yes.
Those are the patients where the orbital apex is involved, and that is most commonly because it is in close continuity with the pterygopalatine fossa through the inferior orbital fissure. So in all such blind patients, even if it is normal looking, you must explore.
Okay. Now, please.
And if you see, if you look at the MRI closely, you will find. See now this area which is left behind.
Yeah.
Rest is okay.
Yes.
Go there. Right. What I will do, I'll leave a small pack behind for time being. Yes. Now my focus is here.
Exposing the posterior wall.
Here.
Yeah.
How simply the orbit you have seen above, how simply I can remove this bone.
So simply trace the sphenopalatine backwards, laterally.
Follow the sphenopalatine with the kerosene punch.
Yes. I can use quickly my chisel and hammer as well. Open up. See the thin bone, I can remove with my blade as well.
Oh, okay. This is, yeah.
See, brother, the branch.
Yeah.
See the vertically down. This branch, which one is this? Greater palatine.
Greater palatine. तो आता चालू.
See, very vascular, and that's a good sign.
Yes, indicating that it's unlikely to be affected.
So, as I showed on MRI, our key was the orbital clearance. You have seen.
Yes.
And you can predict by the MRI so well. See, I told on MRI what is going to happen into the orbit. Kerrison.
So in all cases, are you going to be taking care of the pad of fat in the pterygopalatine fossa?
Yeah, you must check if it is infiltrated.
Yeah, because being fat, the chances of poor vascularity is high.
Yeah, and this is the common pathway to the orbital apex.
Correct.
Kerrison. I can see the vessel well.
Bleeding Rukana.
See the vessel. See the thunder.
This is just for the general audience. I think these vascular clips that we were talking about, Kalelkar also has them along with the applicator, very easily available. So just those who want, they can simply. The Karl Stoves one costs just 70,000 rupees, but the Kalelkar one is much cheaper.
Now, can you see the vessel very clear?
Yeah, very nice.
Let me show you more clearer and see this Karl Stoves clip.
That is it. Yes. That is the vascular clip. Yeah.
That's it. That's it. Could you see?
Yes, very nicely. Yeah.
Is this region, I told you, posterior septum, pterygopalatine fossa, this pterygoid bone, the sphenoid wall, these are important areas one can overlook, and these are the areas to be thoroughly seen to prevent problems, you know. Later. This is the marrow bone. See the bleeding marrow. See the marrow bone of the pterygoid?
Yes, yes, very nicely seen. Yeah.
Divider. So now this is the final part to move on before we move on to the next case. Anybody has any query, any suggestion, anything to add on?
So Ajay, who's getting the questions from the audience? Dinesh?
It was you to decide, Ashish.
No, there's some site that he gave.
Say this. Now I will further last part. Yeah. Sure, sure.
Subhash? ये जरा खोलना तो क्वेश्चन जो आ रहे हैं ना वो दिखाना ऑडियंस क्वेश्चंस
See the entry wall of the sphenoid?
Yes, very nicely seen. Yeah.
Must see thoroughly. It is not uncommon to see infiltration there. Drill. And this is the final part. I am drilling the part of the interior wall. We have ensured everywhere there is no, necrotic region left behind. You can see all bleeding areas everywhere. Just to assess what kind of bone it is. Madam. Section.
Sati, there are already 234 questions.
Divided 40. You can take up Ashish anytime you feel like.
Yeah. What's your take, sir, when to operate if patient is still positive after 14 days?
Yeah, I operate on such patients.
Yeah. I think typically after the 10th, it is known, I think, that they are non-infective. So we've all now started operating. We're not really, we do the RT-PCR, but even if they are positive, I don't think we have the luxury to say no, and we just have to go ahead and operate. But after the 10th day, they are less. The challenge is really of anesthesia. In the early post, this thing is not so much about us catching the infection. I think that talking to the patient's relatives, making the anesthetists actually meet the relatives, I think is very important. Oh, this is the opposite side also? Oh, okay.
Yes.
Yeah. So the earliest I have seen is 10th day, but by the time we could work him up, it was already 3 days later. So we operated.
Ashish.
Yeah.
See the bone.
Yeah.
See the vascular bone here. How easily one can miss. See this?
Yes.
Amazing. Now how will I remove? See, this is the infiltrated bone here. See this one?
Oh. You have to remove, yeah.
Yes.
The entire floor of the sphenoid. What made you suspect to go there?
Because I had to open the posterior part of the septum was involved. So you need to see both sphenoids and the floor thoroughly. See this itself was affected. See this?
Yes, that bone is necrosed, yeah.
Section. Oh, one can easily overlook this again. The hidden areas. The brighter. Now, sphenoid is the key bone. You have to be careful. You have to be radical, both the aspects, keeping in mind.
Would it be a good idea to drill that part also?
Yes, I will. Absolutely.
There was actually a question from Pakistan, Satish.
Yes.
Please comment on the ophthalmic artery here. But that was while you were in the orbit.
Any take on ophthalmic artery?
Please comment on the ophthalmic artery. Yeah.
You don't see once you are debriding, but you're already thrombosed.
It is already thrombosed. This is one doctor, inshallah, from
Yeah, wash. That is why everything was avascular.
Can we use the same debrider for COVID and non-COVID patient?
No. Debrider means blade.
Blade.
Never.
No way. For that matter, these are disposable blades.
There's a question from a dentist, I think. How crucial role can a dentist have in this apart from multidisciplinary? That I think Sandesh already.
Very important role first in diagnosis.
Yeah.
Early diagnosis, because lot many patients present with early dental symptoms.
Yeah, that's
no.
very important. Early symptoms.
And next is rehabilitation. So many times we remove the palate, we remove, radically the part of the palate and the teeth as well. And later on you can reconstruct with a free flap, you can use the titanium, implants and other things. So reconstruction part is equally important later on for improving the quality of life.
There's a question from Solapur, Dr. Sachin. What's the youngest age? Is it prevalent in children? Mucor.
It's not prevalent, but yes, I have operated. I can show you the MRI of a child 7-year-old.
7-year-old?
7-year-old, though it has nothing to do with COVID.
Yeah, okay.
But I can show you if you want after this.
No, related to COVID, of course, we are not seeing so many here.
So now you see, finally I am on this bone. This bone, see this bone? Can you differentiate the bad bone from the good bone?
Yeah.
This is bad bone, necrose bone. See the greenish hue? No, that drill. And I will, this bone, see these are fine points to improve the results.
I think by the end of this Mucor thing, you will come out with a full house Mucor technique, I guess. There's a question from Bukarao. Role of streptokinase as clot dissolver.
No, it doesn't work. For that matter,
not indicated, I think.
For that matter, this is not a coagulopathy, simple coagulopathy. This is not a DIC. COVID induces complement-mediated microangiopathies. So there is no role of streptokinase for that matter, to be very specific.
There's a comment from Birmingham, UK. Hello from the UK. My experience of this disease is in the chemotherapy patient child who is immunocompromised.
Yes.
You are seeing different from the disease seen pre-COVID. We are seeing a different presentation in terms of.
See, it is common in patients with lymphoma and leukemia. The reason is the resultant lymphopenia.
Yes.
Same thing is happening in the COVID. More than 85% of the patients have lymphopenia. That's how the COVID is having all these cases.
Yeah, there's a question from Nigeria. All COVID patients who have uncontrolled diabetes are put on various antifungals to prevent oral candidiasis, esophageal candidiasis, ventilator-associated aspergillosis, etc. Does use of these antifungals kill normal flora and predispose to mucor? You had said that about it.
Yeah.
Which is the best antifungal to prevent all these? I don't think there can be a generalized answer to this.
Mhm. Who is this? Professor Kufre from Nigeria?
Uh,
Ishe Kufre?
yes, that's right. Yeah, yeah.
This gentleman is a dear friend who happened to be with us for a couple of months.
Ah, okay, yeah.
Hi, dear.
I will ask.
Bleeding is encouraging.
So the
See,
problem is,
Ashish.
huh?
See, Ashish.
The
Yeah,
free bleeding is encouraging.
Yes. See the bleeding bone.
yeah.
See the carotid on this side, carotid on this side. Can you see the thin tissue?
Yes, I guess the message here is if we see the posterior half, the septum to be involved, one has to be very radical. I think one has to look into the sphenoids in great detail.
Yeah.
So it's not a limited posterior septictomy that will suffice.
Yeah. And the most important is this orbit. Wash. मेरे को दे. No need of exentration. See, with the exentration, unnecessarily cut section, damaging the important tissue, normal tissue, that is not warranted, that is not our aim. We are not treating a cancer. See this? Give me the divider, 60. See the anterior artery. What do I do?
Do it.
Hello?
Yeah.
What to do with anterior artery? See the vessel.
Yes, it's hanging there. Yeah. Oh, okay. Tempted? Okay. Half the life of a sinus surgeon goes with this as a nightmare.
And the anterior artery is a branch of ophthalmic artery. See this? Completely necrose. Okay?
Yeah.
So this completes this for surgery today.
So Sandesh has already commented and complimented you, Satish.
This is the basic case to begin with today.
Yeah.
So we'll be having much more advanced cases now. See the final picture. Not a glimpse of any necrosed tissue. Can you make out?
Right. Beautiful.
That is the goal.
Nice bloody picture.
So if this kind of clearance will not require, why do give so much of amphotericin now?
So typically, this patient will need 7 to 10 days.
7 days.
7 days.
Just 7 days. That's it. We step down to posaconazole for some time and see this patient. You get the CRP done after 2 days. It will come down drastically. That's it. Thank you very much.
What is the endpoint of posaconazole, Satish?
Pardon?
What is the endpoint of use of posaconazole?
Till CRP comes back to normal, close to normal. When the mucosa is, all the surface mucosa is in the healing phase, final healing phase completely. Volume. So that you don't need to change. Kar do. And the beauty of the Dankers is to give you a complete picture what is happening behind.
Yeah.
See this, with this kind of exposure, you don't need anything. You don't need radiology. You can endoscopically monitor. You can, apply your drugs.
Satish, hold on.
Yes.
Shinde sir is now, he's watched the entire surgery. Because but now he's just
Really?
words and he's going to de-link for some time. Yeah. So
शिंदे साहेब खूप खूप आभार.
yeah.
आपण आले, वेळ दिला. थँक्यू.
Wait. Let him come. He just yeah, he's come. भाई झालं, पहिली सर्जरी संपली आहे, अजून 4 करणार आहोत. So we will go on.
मोठं चॅलेंज आहे होय तुमचं. आणि खूप म्हणजे अगदी कॉम्प्लिकेटेड सर्जरी आहे ही. आणि बघितलं तर म्हणजे
तर हा बेसिक केस होता.
पण असं
आता यापेक्षा ऍडव्हान्स केस येणार.
ही सर्वात बेसिक केस झाली. पुढच्या ऍडव्हान्स आहेत. पण अंटिल असं क्लिअरन्स केल्याशिवाय ना एम्फोट्रेसिन काम नाही करणार. आणि असं क्लिअरन्स केलं तर गॅरंटीड एम्फोट्रेसिन काम करणार आणि जीव वाचणार.
सगळ्यात महत्वाचं म्हणजे जीव वाचवणंच आपल्या हातात आहे. त्याच्यासाठी जे काही करावं लागेल ते तुम्ही करताच आहे. आणि पोस्ट कोविड मगाशी आपल्या डॉक्टर शशांकजींनी पण सांगितलं की त्याच्या आणि आपल्या देसाई सर सगळे रावलजी पण आहेत. याच्यामध्ये तर म्हणजे शुगर मेन म्हणजे शुगर वाढल्यामुळे हे सगळं.
शशांकला मी गमतीत म्हणतो, तू काम चांगलं केलं तर माझं कामच नाही.
लागते. एकंदरीत सगळे तुमचं जे काही डॉक्टरांचं काम आहे ते फार मोठं काम आहे. आणि खरोखर म्हणजे सगळे तुम्ही देवदूत आहात आणि तुम्हाला सॅल्यूट केला पाहिजे.
नाही सॅल्यूट नाही, तुम्ही साथ द्या बस.
एवढंच मी म्हणेन, बाकी काय मला शब्द नाही आहेत. हे सगळं जे काय बघून आणि सगळ्या ज्या काही एवढ्या म्हणजे मायक्रो लेवलच्या ज्या सर्जरी आणि कॉम्प्लिकेटेड हे सगळे, आणि माणसाचं शेवटी आपण कुठलेही काही शेवटचा पर्यंत प्रयत्न सोडत नाही. हा याच्यातून आपल्याला दिसलेली जी काही बाब आहे. त्यामुळे मुख्यमंत्री महोदयांच्या वतीने मी आपल्याला धन्यवाद. नक्की पुढच्या वेळेस मुख्यमंत्री महोदयांना आपण विनंती करूया.
एवढा वेळ दिला
परत एकदा मी
एवढा वेळ दिला आणि एवढं आग्रहाने इंटेंटली बघितलं. थँक्यू सो मच.
खूप धन्यवाद शिंदे साहेब. आले, एवढं वेळ दिलं आणि एवढं इंटरेस्ट ठेवलं आपण सायन्स मध्ये. आणि खूप खूप आभार. थँक्यू.
थँक्यू, धन्यवाद. आपल्याला सगळ्यांना पुन्हा एकदा मनापासून मी धन्यवाद देतो. पुन्हा भेटूया आपण.
थँक्यू सो मच. थँक्यू.
Thank you, sir.
Thank you, sir.
Thank you very much. Ashish, do we go ahead with the next case?
Please go ahead.
Ashish?
Yes.
Go ahead.
So, are you getting the MRI pictures?
Yes, you can see.
See, these 2 pictures are telling everything. Are telling everything about the disease extent you can make out. Would you try to read what is happening on the right side? Look at the fat suppressed T2 and the contrast and see the condition of the orbit.
Yeah.
Look at the condition of the orbit. All rotten, non-enhancing, devitalized tissue has almost completely replaced the orbit. Can you see?
Yes.
Look at the normal orbit on the opposite side.
Hello, namaskar.
What better picture can you see for the orbit? And see what is happening there?
Yeah.
This thing. Back, Atane. Back. See what is happening to the orbit? Full of disease. Full of infectious material into the orbit. See the ethmoids. See the non-enhancing material in the ethmoids. Turbinate is almost replaced. I mean, no blood supply, no turbinate is shown on contrast, means completely replaced by the dead tissue. and see the maxillary sinus. And if I go behind, this is the pterygopalatine fossa, and you will find everything rotten.
Yeah.
This is the depot of fungus, massive fungus into the pterygopalatine fossa and into the infratemporal fossa. Can you see this?
Absolutely.
Infratemporal fossa, pterygopalatine fossa, posteriormost part of the maxillary wall, and from there to the orbital apex. See this?
Yeah.
What a picture.
So this far laterally, the infratemporal fossa is involved.
Yes, that's the infratemporal fossa. He has some infarctions also in the brain.
Yeah, we can see that.
Have been totally counseled as those are going to recover on their own. The thing which you can do is to prevent the further spread of the primary disease so as the infarction can recover on their own. But this is a high risk situation. You need to tell your patient beforehand what is happening there. See the infarctions in the brain. See the condition of the entire orbit completely replaced by this mucor, this entire infratemporal fossa,
Yeah.
mucor, entire this infratemporal fossa, pterygopalatine fossa, this is the orbital apex, maxillary sinus, maxillary wall, and it terminates right up to the sphenoid wall. See this sphenoid wall. Look at the opposite side vascular thing. Can you see?
Yes.
Can you see the vascular middle turbinate on the opposite side and this side difference? So easy, isn't it?
Yep.
Ashish, can you see this?
Yes, very clearly.
Middle turbinate on this side.
Yes, Satish. You can see it very well.
See the floor of the sphenoid on this side.
Yes, well enhancing. And yeah,
And look at the floor of the sphenoid here.
yes.
All totally necrotic.
This is pterygopalatine fossa. This is pterygoid fossa. Can you see?
Yeah.
Yes.
Completely replaced by this material, and that is what a picture shown on T2 as well. Entire orbit is replaced. This is the orbit full of fungus. You just put your debrider and remove everything. As simple as that.
Yeah.
The true debridement you will witness here.
Orbital debridement. Maybe you should come.
Yes.
Yeah.
And see the entire middle turbinate, inferior turbinate, everything gone. What a pathetic situation this patient is suffering. And I will show some more. This is contrast. So these two pictures are telling the entire story. And this is the...
So when Satish, when not to do a modified Dankers?
When not to?
When not to do a Dankers?
See, once you have an early disease involving the lateral nasal wall turbinates, without going laterally anywhere, that is the early stage if you can pick up. We pick up less than 10% of the cases in this state. With the current awareness, with a lot of patients coming with, fear of mucor, particularly diabetics, I have excessive, itching in the nose. Doctor, can you see if I am having mucor? See, any diabetic patient with excessive crusting, assume it is mucor until proved otherwise, I can say. So those early patients, if you get, you don't need to do all this bullshit debridement. Now see the diffusion weighted MRI about the infarctions this patient has developed. Can you see?
Yes.
And that is something important. We told this patient beforehand. We told them you have already developed infarction. That is a massive stage of the disease. And you need to understand the chances of neurological complications are high. In spite of having done a good surgery, good therapy, everything, you have to be ready for the neurological consequences if happen to develop. Otherwise, if you don't get this and develop this picture later on after surgery, everything falls upon the surgeon. So this is very important. It's not that you're ordering n number of unnecessary sequences of MRI. Every sequence has a value.
True, very true.
And in this era of the medico-legal litigation and all this, you have to be very, very cautious. And it is good for the patient to know the real, status of the disease as well.
This is a very interesting question. Post-op steroids.
Come on.
No, there's a question. That we use in normal post-op phase required or not? No.
See the status of the immunity of the patient because of the steroid. And now giving the steroid is as good as giving a poison to the patient.
I mean, we have to answer it. Yeah.
So we are all set for the second case.
Yeah.
Do we go ahead?
Yes,
Yep.
please go ahead. Yeah.
Please
And
go
the third one will be more mutilating, more extensive, along with the skin and everything, the entire maxilla, pterygoid, sphenoid, everything has to go radically. With a free flap, later on, if we are able to get a complete clearance,
So
confident of.
that would be
Yeah,
smooth.
Sanjay Devre, I think he's doing a lot of work in that area. He's among the few ones where it is almost like a center. If he's there, he should come now and start commenting. Gaurav, you too. I know you're also doing mucor work. If you're listening.
Yeah, Gaurav is doing a lot.
Yeah. And Sanjay.
Vivek is doing, Amol is doing.
Oh yeah. I mean the whole hardcore team is very much on.
Yeah.
Just a comment on the case that we did earlier. If you see the involvement of the eyeball and the involvement of the nasal mucosa, if you see the inside, there is a lot of difference in that. The predilection for the eyeball was it was unreal. I mean, the way there was no vision and the kind of the fungus that was invaded in the eyeball. And if you see the sinuses that were involved, usually what happens is if there is if such kind of a massive involvement of the eyeball, you see the sinuses also, everything inside the nose, it appears black. But in the previous case, the mucosa was pretty healthy. Apart from the middle turbinate and all, if you see the eyeball was, there was a lot of discrepancy. So it is not a fixed thing. And as sir mentioned earlier, you have to take all these cases earlier. The earlier, the better.
Sure. Who was talking? Who's this?
Yes. And see, one more thing. This observation on this patient about the involvement of the ethmoidal roof, the dura. I am suspecting the dural involvement here in this area, particularly just behind the sphenoid sinus, the frontal sinus, in the anterior ethmoidal roof. See this lack of advancement of the dura in this region. Can you appreciate?
Yes.
So this focal dural involvement is likely in this particular patient here. So let's see how it goes. But I can see the disease, the mammoth disease, everywhere, it has ruined. See this entire avascular zone. Nothing in it. So we go ahead. In a couple of minutes, we'll be back with the surgical picture. Meantime, you can take questions.
Yeah.
Ashish, any more questions coming to you? We can take meantime few minutes.
Yeah. 1 minute. Let me look at it again. Post-op packing is done or not, and when to remove?
What?
Post-operative, is there packing done, and when to remove?
Yeah. We remove next day.
Next day, yeah. Okay.
Yeah, just prophylactically for a day. And see, all these intracranial patients, like this patient, we have planned to start, low molecular weight heparin from tomorrow.
From tomorrow?
Who has already developed infarctions. So all patients having venous or arterial thrombosis anywhere on angiogram, venogram are supposed to have, this anticoagulants, particularly heparin, and all those things to prevent further thromboembolic episodes.
There is a how to prevent medial rectus prolapse. I don't think there is.
Prevent what?
Medial rectus prolapse.
Medial rectus.
Yeah.
See,
Doctor.
it's not that medial rectus is well ensheathed right from the globe to the orbital apex with a good layer of fat, particularly anteriorly. So it may get fibrous, but it doesn't really prolapse. Rather, when it gets fibrous, it retracts more rather than prolapsing.
If the vision is normal, do you reconstruct the orbital medial wall?
Not really. It doesn't make any difference. The fibrosis takes place. You don't need to reconstruct.
So Shalini Saxena from Chennai, is it advisable to take these patients under the coverage of amphotericin B, or you can take them directly for surgery?
Yes, until the patient waits for surgery, waiting for his turn. Like for us, it's almost, the waiting is so much that you can't take up the case immediately. So immediately you should start amphotericin B at least to prevent, further spread by taking care of the enhancing areas. So it will help to some extent.
Yeah.
But
yes. People to know Satish is doing at least 20 cases a day. He has 62 patients admitted there. Plus, he has had to rent out a hotel in front of his hospital, which is about 50 or 70 room hospital, where post-op the patients are getting their amphotericin and other care there. It's a national drainage center. So people and VIPs from everywhere are just thronging. So it's very difficult for him to find time now to even answer. But nonetheless, he's always very, very cooperative, and you send him an MRI picture, he will read it out for you and tell you which compartments are to be opened. So he's doing a phenomenal work. I think it's again the record of the sorts ever in the world. This kind of Satish. So congratulations. I mean, this is nothing new to you, but it's incredible.
Ashish, Sandesh here.
Yeah, Sandesh.
Can we go and just touch him once?
Yeah.
Get the energy.
Take his hands. We are planning to go, Ashim and I, if I manage to keep the protocol on Wednesday or Thursday, we are planning to go. So we do 10 cases in a day and come back. We'll go for a day or two, but depend on how the lockdown situation is. In fact, we hope we'll be of help to him and not a burden.
And that is a very modest statement coming from one of the guys whom I regard as one of the 5 best ear surgeons on the planet. So there you go.
Yeah, can you change to the endoscopic picture, please? Endoscopic.
Yeah, we are on.
Ashish?
Yes, you're there.
Ashish?
Yeah, Satish, we can hear you.
Naresh?
We can see the endoscopy picture.
Look at the picture.
Yes, oh God.
See the massive, necrosis.
Yeah.
See this crusting is the principal sign.
Sandesh just complimented you. He says, let's go to Jaipur and shake Satish Jain's hands.
To get the energy.
He's most welcome. He's most welcome, sir. Are you now? Okay. See this picture? All necrosis?
Yes.
Sandesh Maker, sir, in this era of mucormycosis, we had to remove so many alveolus, upper alveolus.
But how can we do reconstruction of that later on?
Immediately, we don't do anything until the patient recovers completely out of the problem. Meantime, we give them a obturator. And then later on, our plastic team does a lot of things, free flap, our dental implants and all those things.
There is small suggestion that if you can make before you operate, make a pre-impression models keep it ready.
See,
So reconstruction will be very easy.
yeah, I know, but the reconstruction limits are not defined pre-operatively.
That's true, but at least we get a fairly good idea of maxilla, how the size is, and closer to that.
Yeah, and secondly, we don't intend to, reconstruct immediately, because the immediate concern is this disease and how the disease course is going to be, and we want to keep all areas open for our assessment also.
Okay.
Oh, it is all dead only, the whole septum.
All everything. See, this crust on the septum means the vascularity has gone.
Yeah.
Yeah.
As simple as that. See the kind of disease it is.
I have struggled through in my early microtia days, struggled through skin necrosis. I know what it means to have a skin necrosis. I had
This man
World Congress that the skin not only talks to you, it screams at you just by changing its color.
This man being a sort of VVIP.
This patient?
Yes, underwent COVID treatment.
Is he the Gujarat, Ahmedabad guy?
No. There are only Gujaratis VIP.
No. You mentioned to me on the phone. No.
So this guy developed COVID, and his CT score was 3. And he was given dexamethasone IV.
Because he's a VIP.
Yes.
Prevent the storm.
Because nobody could imagine what a steroid can do.
Yes.
Actually.
No. Now they will shudder before writing a steroid.
See, this all septum is gone completely.
But I'm afraid they'll come out with some new drug and we'll not know what that new drug is going to be doing.
Every day in market is a new drug for COVID.
Yesterday I was a guest speaker at the Stanford Task Force, and they actually asked me the question about cow dung and cow urine.
God.
And is that one of the causes of this black fungus?
See the entire septum.
Very disgusting. Yeah, it is all cyano.
I'm just uncovering the areas just for assessment.
Totally cyanosed.
Yeah. See now, let's get on to the.
Hitesh is saying hi to everybody.
Hello, sir.
Hi, Hitesh. How are you?
Later.
म्यूकर के फरिश्ते.
हितेश भाई.
जी सर.
के फरिश्ते म्यूकोर के दुश्मन.
पेशेंट के लिए फरिश्ते. सॉरी, यू आर राइट सर.
See this, the same level. I am doing the same thing again and again.
Yes, Satish. Now this we need to, it's an excellent.
Modified Dankers.
My idea was to also learn this technique in details, so that, because many times we're getting a question, why not a Caldwell approach? Why do such a thing? Because Satish give the answer, the post-op surveillance, there's no other technique that can give you.
This posterolateral spread to the maxilla can be easily missed if you don't do this.
Yeah, one is for
try to do this in cases where there is posterolateral spread, the pterygoid spread, the infratemporal fossa spread, and you'll not be able to reach out there, and one can easily miss. Even after you open, don't open the areas behind, you can miss. And that is the single most reason for the high mortality.
Yeah.
Leaving the necrotic areas behind.
At your center, the mortality is less than 2%, 5%?
Yes. But we get very, very extensive patients.
Yes, sure, sure.
I will show you after this case an MRI.
Maybe if you have a way to look at the minimal disease, I believe your mortality rate will be less.
Yeah. Minimal disease, no mortality. But I'll show you the kind of patients after this. Patient, tomorrow we are operating at a huge frontal lobe spread.
Wow.
I'll have to bring the part of the frontal lobe with my, fingers.
So let's do the live demo tomorrow, at least for us, not the general Zoom.
So there are many extensive spreads. And there the mortality is definitely very high.
So why are you operating?
There's no other way. Patient is a young fellow. Has been explained, there is no other treatment. Otherwise, he is going to die for certainty. We can at least try to save him. Obviously with deficits, but life is life.
So you will be approaching that case from above with a bicoronal incision also?
Yeah, combined approach.
Combined approach, yeah.
Vivek was mentioning that there are many maxillofacial surgeons who are doing an open approach.
No point for this open approach, boss. Unnecessarily adding on to the morbidity. Unless the outside skin is involved.
No, for routine cases.
That is not warrant. Again,
Then
you do open approach, how will you do surveillance?
It's true.
Yeah, you can do sublabial, how will you do surveillance? The problem is the surveillance, because many of these patients will require some or other sort of debridement again. If you miss something, if you are following properly, if your CRP is rising, condition is not improving.
That's manifesting as crusts again in those areas.
Pardon?
How does it present itself? When you look inside, you start seeing the crusts again.
No, but post-op crusting also will be there. So how do you differentiate?
Yeah. Saline wash is the key. For post-op crusting, you mean to say?
No. How do you differentiate residual disease vis-a-vis routine post-op crusting?
Yes. So post-op crusting is definitely there, but the mucor, you remove the crust, you'll wash. Dhar. So this is your entry into the maxilla.
Yep.
That is the roof of the maxilla.
Yes.
Level of the roof here. Let me show you. Very clear. And this is your nasolacrimal duct. See the turbinate. Carison.
Yes, very.
And see the level at the floor of the orbit.
This little fine detail of the Garrison punch to not damage the nasolacrimal. I had missed.
Drill. Yes. So
I'm
Garrison is a safe tool.
a little bit reckless. I was drilling there, and but I think this makes more sense.
Garrison is a very, very safe tool. See the drill.
Yeah.
Coarse diamond.
How much does this model cost, Satish?
35,000 for every,
For the
drill bit.
No, you said the entire model is a new one?
Yeah. This costs 12 lakhs, probably. MR8. This is the advanced version of stylus. MR8.
MR8. Okay, yeah. Already looks
That's
old.
It's too good.
20 cases a day. What do you expect?
The earlier stylus was for 40,000 RPM or 60.
No, 75.
This one is also 75, no?
Yeah. It is much more precise, a better version.
Acha.
See, it is companies gimmicks also to bring out new versions.
Of course.
Business strategies. Yes. See, my goal is to reach to the posterior wall of the maxilla.
Yeah.
This so far, I have not done anything to the pathology by and large.
Yeah, exposure.
Exposure. My exposure to the floor of the orbit, which is our area of interest. Exposure to the posterior wall, which there is tons of fungus there behind. We have seen on MRI.
Yeah.
See this?
Yeah.
This bone, this is osteomyelitic bone.
You can tell from the color, although it's bleeding.
Yes. You see many a time the posterior wall of the maxilla. Do you see like this?
No.
Lusterless, whitish bone.
Correct. And the
pure osteomyelitis.
Colored, yeah.
And I'm telling you, I'm expecting from MRI the tons of fungus behind this.
This will have made the bone at least very weak and fragile, no?
Yes. And such bony involvement, you'll see after once I remove this bone, no vascular tissue behind. What will amphotericin do? One of the major causes of shortage of the amphotericin is the irrational use as well.
Yeah.
I've seen patients given amphotericin for 1 month, 1.5 months.
And sometimes they still won't do well because...
And no surgery done.
And they won't do well because ultimately the area of interest is not reached by the amphotericin.
The liposomal version is very renal sparing, kidney sparing. It has.
Yes.
Compared to deoxycholate.
Yeah.
Otherwise, but it still is a problem. The more renal sparing one is the isavuconazole.
Yes. We have few patients whose creatinine is very high are on isovuconazole. Wash. Yes. Anyway, leave it. Now quickly I will remove the turbinate. This is my exposure of the floor of the orbit.
Yeah.
Yeah.
Now I will expose the medial wall of the orbit.
Is laterally the bone looking little also there? Yeah.
Pardon?
And there where you're touching, the bone is looking bad.
Yeah, this is all bad bone.
Yeah, the floor of the orbit laterally.
Yes, yeah. I will remove this thoroughly. See, this is all bad bone.
Yeah.
So there is a lot of visual and tactile clue that is directing besides the MRI.
Yeah. See, MRI is for your planning. You know, I know everything where the fungus is going. See this?
Yeah, you can see the color all black down.
All black.
Whole septum is going to go. See the lamina. Can you make out the involved lamina papyracea?
Yes.
See this? Normally the lamina is a
Smooth and it's irregular.
thin, yes,
The texture has changed completely.
totally.
Texture, color, everything.
I forgot to.
See this? Look at the sphenoid. Oh my God. I told you this is a massive case.
See the terrible quality of the mucosa there.
Yeah, all
Horrible.
dead. We saw the MRI terribly,
Yep.
See the skull base?
Roof also.
Yes, I told you. See the skull base?
Yes.
Before going to the orbit, widen the exposure all around. So get more space for working inside.
It's very strange in this case. On one hand, you see this pale and osteomyelitic bone, and the second hand, you see brisk bleeding.
Yeah, this is the soft tissue around. Yeah.
Reactive inflammation, Ashim.
Well, exactly.
Yeah.
Oh, give me a pack, small pack. See here, this area
Yes.
is the depot of fungus in this case. I tell you, this area.
Right.
What I have seen on MRI, this area.
Yep.
That and the orbit. So that's the.
And see this MRI, what you see, your radiologist may not give surgically relevant details. So you need to see on your own. Radiology will report opacification of these sinuses, this area could be fungus. Now, how surgically you plan your case is altogether different. Gobleter. Is the source of bleeding?
Yeah.
That's it.
Oblator has really revolutionized.
Oh, absolutely. Now, before going further, give me the this thing. I will take the see the entire septum is going to go.
Yes.
Sujat. See the opposite turbinate?
Yeah.
Yep.
Only surface, but not that much affected.
Just the inferior border is little suspicious. So if you find them at this stage, Satish, like the left side, just debride the mucosa.
Yeah. Obviously.
Better to remove the turbinate, no?
Yes, sir. Turbinate is the first site. Cautery. Turbinate is the first site to get affected. Section.
Because when we find the findings like this, it is better to resect the entire turbinate.
Yes. See this bony bleeding?
Yeah.
Yeah, the section cautery is the key. Section. See the state of the turbinate inside. So just keep an eye endoscopically, radiologically until the inflammatory markers come down. And keep the patient informed in case of some debridement, need of some debridement arises later on.
Anteriorly.
Brother. Brother. Now see with this much of excess. Hello?
Yeah, Satish. We are with you.
I'll be having full space to maneuver anywhere in the cavity.
Yeah.
Not only cavity, skull base anywhere.
That was the floor of the sphenoid that you said was weak.
Yeah.
Your debrider has just punctured it.
Yes, serious.
Yeah, that's the necrosis.
Absolutely.
Yeah, that's the necrosis there.
Once septum is gone, remove the rostrum. See thoroughly the sphenoid behind.
This is what you had told me my day before's case. You told me, na, remove the.
Yes.
Yeah.
Wash. मेरे को दे. See, let me give a good wash. So now a much better picture. We have done the Dankers.
Yep.
We have removed the septum. We are on the sphenoid. The skull base is in front of us. And now, first of all, before going into the orbit, let me complete the sinus work first. Carry son. Or give me chisel. Chisel is faster. See the opposite sphenoid. In this patient, there is a key to clear the infratemporal fossa and the pterygoid. I will show you. Yes. See this big chunk of bad bone? Divider. See the state of the opposite sphenoid. There's some secretion inside. It is bad mucosa. How the picture is good there?
Excellent.
My God. See, this how much is the risk for the opposite eye? Yes, disease everywhere, the skull base, ethmoids. This patient is just 15 days post-COVID. See the kind of spread in 15 days.
Patient without a history of COVID, but has now is a diabetic and now landed up with mucor. I believe he may have been an asymptomatic
COVID.
COVID.
Yes, definitely. Most likely, I would say.
Yeah. So he has not taken steroids. That's what the history I am told.
Cool. See, so much of the work is required in this particular case. Everywhere is necrosis.
Yeah.
These are the real challenging cases. See this all bad
Yes, the mucosa is also thickened and worsened.
vascular. See all necros. My goodness. See now the underlying bone is good on this side. Wash. See the underlying bone.
Yes, Satish.
On left side is quite healthy. Debrider. Long way to go.
Okay, to go. Yeah.
This floor must be thoroughly removed to have a complete look of the inside floor of the sphenoid. Otherwise, you see this here, one may miss the disease. This floor must be thoroughly removed, entry wall.
Yeah.
See this involved bone?
Yeah.
See the floor. All osteomyelitic bone. All osteomyelitis.
Yeah.
Yep.
Use was everything has to go. In such cases, if you leave anything,
But if you don't mind, can you clear the field?
yes.
There was a question, the previous case, Aziz from Thane only has asked, how the orbit got involved in this patient as the maxillary sinus is clear. That is precisely what we are talking about, the angio invasion of this. It does not
Yeah.
destroy everything.
If this patient is a direct extension,
Yeah.
I will show you from the inferior orbital fissure. Now see the sphenoid opposite side. See the bad mucosa.
Yeah.
See the high pressure, high power section.
Yes. Yeah. That I think is very important. See, at no point Satish's debrider is getting blocked. We've all invested in those. They just cost 35,000 rupees. But each one of us has, I think, 3 or 4 of these very high powered suctions, which we apply, keep one suction there and we keep one for the debrider. So the assistant does not have to keep on unclogging. So first of all, the blades don't get clogged. And the blades actually live longer because the efficiency is that much better.
Oh my God. Now, let me show you. My entire work so far is with 0 degree. I have not changed the scope.
Yeah. Probably only for the orbit you need the 70 now in this case.
Yes. Now, this area is full of fungus. This one.
Yes.
I had suggested by MRI.
Yeah.
Give me rider 40.
There is a question. Have you ever seen the tongue being involved by mucor?
Never actually.
Never.
See the roof area. This is still with a 0 degree, but it's all bad. See the ethmoids.
Yeah.
Boss?
As expected.
Yes.
Yes.
Satish boss?
Yes, yes.
Can you demonstrate? जैसे अभी you have removed all the structures. Now, in this field, if we want to open the frontal sinus, so
I will definitely open the frontal sinus. Number one.
What landmark we should be looking for?
See, when you are doing endoscopically, particularly removing from the sinuses, you need to establish further patency, drainage of the sinuses to prevent further sinusitis. Definitely, I will show you.
There's a question from a top neurosurgeon, and you can guess the name later. If there is a dural breach with intact arachnoid, what will you do?
Intact arachnoid.
Yeah.
You have to think of reinforcing if it is a big one. But dural breach without arachnoids, how and why it is going to happen, I don't know.
This question is coming from Pankaj Gupta of Jaipur.
Big boss. He's an amazing neurosurgeon.
That's why I said one of the.
The time we have spent together in skull-based cases is something amazing.
Another question: can nasal endoscopy be normal with mucor in the maxillary sinus or beyond?
Okay. What can you repeat?
Can the diagnostic nasal endoscopy be normal?
Yes.
In the
yeah. If it is somewhere else, it could be normal. In certain percentage of cases, we have seen to the normal diagnostic endoscopy, and yet mucor was there.
Then they obviously presented with some advanced symptoms, some complication already.
Hello.
Yeah, Satish.
Yeah, now I'm changing to 70.
Okay.
I'm going to two areas one by one. One is orbit. This skull base, I will, flush with the drill thoroughly.
Okay.
Later. First, see the key area orbit.
The mucor lady from Surat, Dr. Venus, has joined us.
Welcome, Dr. Venus.
Thank you, sir. It is always a pleasure to see you.
Thank you. We need your inputs for everyone's benefit. Please feel free to share.
Yes, sir. Sir, in revision cases, what should be the clearance so that we don't need to reoperate again?
Any
in revision cases, how much clearance one should do?
Yeah, that's what we are discussing. We have to be thorough in clearance. Otherwise, revision is imminent.
So one of the areas that Venus, he said, I don't know whether you were there already, was the septum. What we tend to do.
One septum, second the sphenoid. See, it is the bone of the sphenoid and the septum, the maxilla, which is most often affected. And leaving behind in the bone, any of the bone, is the principal cause of, need of revision. Then overlooking certain difficult areas, looking seemingly normal, yet having invasion inside, is something called for a revision. So be careful those areas. See, this is the floor of the orbit.
So nowadays, amphotericin B is very difficult to get. So many patients, they are just going from one pharmacy to another getting this amphotericin. But should we debride such patients before they get amphotericin, or we should wait for them to get amphotericin and then start the surgeries?
Don't wait for anything either, I would say. The patient is with you, debride earliest. Waiting for the debridement, start amphotericin earliest. Section. So you don't have to wait for any reason. Early debridement, early amphotericin, early overall treatment is the key to success. See this guy presented with blindness and nobody could diagnose the mucor going on. But this much of spread which has already happened. It's difficult to digest. See what I'm removing? Floor. Can you see? Hello.
Yes, boss.
Yes, we can see.
Key areas now. Keep an eye. This is the floor.
Yes, very nicely seen.
And below, this is the pterygoid fossa area below. Remove the floor and the medial wall adequate for the good orbital clearance. See this? Medial wall. What is there inside the orbit you have already seen on MRI?
Yeah. It's a mess.
There is no orbit, there is only fungus.
Now give me the debrider. See the period. See what is coming.
Oh, it's liquefied.
I told you what is in the orbit from MRI.
This is what you were telling. I think microbiologically you can probably decide which is going to be.
So Ashish, what is the amphotericin going to do?
Yeah.
Liquefactive necrosis.
There, even more. Yeah.
All lost.
Going to be even more.
See the difference in the CT and MRI. Oh my God. What a disease load it was. What is it? So this orbital clearance is a very tricky step, I would say. You have to be radical at disease only. See this?
Yep.
See the necrosis, amount of necrosis.
Huge.
Can you appreciate?
Yeah. You can see the muscle very healthy.
The picture is good. Yes, इसको यहाँ रोक, इसको यहाँ रोक. Yes, no problem. See, I'm retracting with the J curate. Oh. The brighter.
Yeah.
Satish, you're on 70-degree scope, right?
Yes, yes. Always 70, always in orbit. See, our target is very clear. Not everything, but avascular tissue. This is all, the wash we are giving. Oh, the brighter 60. See the state of the orbit, much better now.
Yeah.
It heals well. They do so well once you remove the rotten material. But now. The decision making about the complete debridement of the necro tissue is very important. One can easily live. There is, on the slightest suspicion, we are supposed to remove the or necrose material. See, still.
Yes.
Sanjay, please start giving comment. Dr. Sanjay Devre is back now. Hello? Sanju?
Ophthalmic friends may not be liking this, what I'm doing.
Actually, good point. What is the actually role of an ophthalmologist in such COVID management? Besides diagnosing at blindness level. Diagnosis and
See all around what I'm doing?
Yes.
Looking for any. This is how you have to examine 360 degree. Because going back in the orbit after some time will be really difficult. After the fibrosis happens. See, everywhere healthy.
other than the septum and I believe the unexplored pterygopalatine fossa, have you found other regions in revision?
Revision? Commonest is the pterygoid region, pterygopalatine, and all wings of sphenoid. Lesser wing, greater wing, pterygoids. These are all wings of sphenoid. And without doing a Dankers, you can't do an adequate clearance from all these areas.
Yeah.
For the trans-pterygoid approach, the first step is the modified Dankers. See, the orbit is thoroughly cleaned up. See this?
Yeah.
I will show you 360-degree again. This is towards the apex. खुल गया दूसरा दे see towards the apex.
Yes.
Optic now.
Correct.
And then across the optic now. See everywhere?
Yeah.
So my orbital part is done. See this. The next part is again. Oh. See, this is something, a massive surgery. What a mess is spread. Still, we have a lot of work to do. We're not even done 50%.
Skull-based drilling is going to be something special.
Hmm?
The drilling of the skull base is going to be something special, I think.
Yes. Yeah. That is still left.
Long way away, but
remember the initial picture when we started the case.
yeah. Hi, Deepak. Deepak Dalmia has also joined.
What I'm removing? Floor. Can you see?
Yeah.
Hello. Yes, boss.
Yes, we can see.
Key areas now. Keep an eye. This is the floor. Yes, very nicely seen. And below, this is the pterygoid and fossa area below.
Something we can hear you.
And the medial wall adequate. Good orbital clearance. See this? Medial wall.
What is happening? Hello?
Yeah, I don't know who's talking or some another.
Hello, Dr. Ashish, Dr. Satish.
Yeah, Deepak, hi.
How are you?
Good to see you, Deepak. How are you?
Satish, actually, I want to know. So you said
What is there inside the orbit? You have already seen on MRI. Yeah.
in the beginning you said.
Why it is repeating? Why it is coming? Audio visual. Have they played some other video? Come on.
It's saying loading something, God knows.
Dinesh ji.
Unless there is a clone of Satish Jain that has been produced by scientists.
See the period. See what is coming. Liquefied.
Come on. What is
on somebody's phone.
Right.
Is somebody
telling microbiologically you can probably
something
on and there's a delayed signal coming through.
What is amphotericin going to do?
Dinesh ji.
Effective necrosis. There, even more. Yeah. Even more.
पहले की आवाज आ रही?
हाँ.
In the CT and MRI.
10 minutes back we spoke about this. Deepak, 1 minute. There's some audio overlap. We are trying to.
Dinesh ji, the old audio is coming.
10 minutes back, what we spoke is getting.
दिनेश जी ऑडियो पुराना क्यों आ रहा है? मैं तो यहाँ खड़ा हूँ.
Oh my God.
See this?
What a disease load it was. What is it?
Is somebody's phone on?
Clearance is a very tricky step, I would say.
Could be someone's phone. Can you mute all?
You have to be radical at disease.
बोलो ना. दिनेश को फोन करना.
Yeah. See the necrosis, amount of necrosis.
Dinesh ji, mute all first. Mute.
Can you appreciate? Yeah. Very healthy. The picture is good.
हेलो.
हाँ सतीश.
10 मिनट पहले का ऑडियो आ रहा है.
हाँ.
तो जूम को म्यूट कर दो ना एक बार.
किसने ज्वाइन किया है?
हाँ?
But
so those who are on Zoom,
there is nobody. Everybody.
Webinar exit the webinar link. Those who are on Zoom, exit the webinar link, so the voice overlap will not be.
Now it has stopped.
Stopped?
Yeah. Okay. Yeah. Thanks. Thank you, Dinesh. Carry on. Deepak, you had some question? Deepak? Yeah.
Yes.
Yeah.
Actually, in the beginning, Satish said that monitoring of CRP is
Yes.
Means we can judge by monitoring the CRP. Is there any inflammation? Is there or not?
Yes.
Suppose if the post-operative granulations or this, that will also raise the CRP or that will not raise the CRP?
Granulations will not raise the CRP. The healing, if the inflammation is gone, the CRP will go down.
I am just asking.
Yeah, yeah. Let Satish answer. Satish?
Yeah, Deepak.
Yes, boss.
Deepak, CRP is a non-specific marker.
Okay.
Now, with this much of disease load, the CRP is on, on the sky.
Yes.
200 and more.
With the clearance, the CRP should come down drastically.
Yes.
Now the inflammation will go on. So the CRP is not going to come back to normal immediately.
Okay.
It will remain raised until everything heals up.
Okay.
Now, if the CRP doesn't come down practically, significantly, or it started rising,
okay,
that is the key to know that something has gone wrong.
Okay.
Now coming to the next key area.
Yes.
Again, I told you from MRI, the depot of mucor. Now I am opening up. I hope the picture is good now.
Very nice.
Oh. And one more question, just give us two messages for all of us. When you already answered this, when we can avoid Danker, one thing, and can you suggest something some advice to the physicians, means don't discharge patient before controlling the blood sugar, something like that?
That is, Ashish has already mentioned about the guidelines coming up.
Okay.
So the blood sugar control is the key part of that, obviously.
Any role of normal saline spray in COVID patients?
Normal saline?
Just nasoclear or sol spray type of thing, any role if we advise?
You have to do washes, boss. What the sprays will not be adequate,
You're breathing it 24/7. So just washing it one time or two times is not going to be.
See, this is what I'm doing.
Yeah.
See?
Yes, I can see the box. But this time very
I'm opening the magic box.
Yes, but this time you made a big box.
That's because the disease is going far laterally.
Knowing from the MRI, I know.
Yes.
Ashish, you sent me that video that day about the pterygoids, no?
Yes.
See this. See, can you imagine this without doing a Danker? Hello?
Yeah.
Without doing a Danker, can you imagine? See the magic box. See what is there behind. Gift pack of mucor.
Mop it and show us. We could appreciate. End of the month, you will see mucor only, even in your sleep. Any surgical tips about now going forward from here?
Yeah, this is infratemporal fossa, man.
Yeah.
All muscles, nothing else.
And how you prevent the thysis? Just I am asking, we want to extract from you as much as we can. Thysis of the eyeball.
What eyeball?
The sunken eyeball after this.
Yeah, it remains little bit sunken. But imagine the picture after exenteration.
Yes.
And you can reconstruct this orbit later on.
Yes.
Sunken eyeball, you have to put some fat or some material inside the orbit. Can you see this, man?
Yes, yes, yes.
See, Ashish, the box.
Yeah. We can see very well.
How could I predict?
Oh, on the MRI. Yeah.
Yes.
And when it is necros, you can use the debride. Otherwise, how about cobbleter here?
See this? See all this.
Going so far laterally.
See this? Above is the V2.
Yeah.
Which is involved by the disease. The patient had full numbness. No sensation at all. Yeah, cobbleter. See your vessel?
Yes.
Yeah.
Yeah, I can see.
It's up to means where you think that clipping is required, or we can manage this with this cobbleter.
Pardon?
When you decide that clipping is required, or you can manage with this cobbleter.
Clipping is the most definitive way. That's the best way to ensure that it is not going to reopen in the post-op period.
Yes.
See, material, boss.
Yes.
Right. See what I said.
Yeah.
Pterygoid muscles.
See the magic box. V2. See all rotten. See this.
Oh God, yes, even beyond that.
I told you, if somebody is operating without MRI, what do I say for him?
Send the patient to Satish.
No, it's not that I am going to.
Satish won't do without the MRI.
Huh?
You cannot operate without the MRI. It's as simple
as that.
Yeah.
It's not.
No, when I was talking to Satish, he said, can you do a FES with an X-ray PNS? You can't.
Agreed.
So
as simple as that.
Example he gave me.
While just showing this, can you please tell us in brief about what is T1 weighted, what is T2 weighted, what is flare? You already said, but can you repeat again for the sake of people like us?
Sure.
Very good question, Deepak.
See, Deepak, MRI, every sequence has a value. You need not to remember. See, every sequence picks up something.
Yes.
Contrast will show you the areas of vascularity where the gadolinium goes.
Yes.
T2 will show you the fluid as a hyper intense signal.
Yes.
All T1, T2, all sequences, the fat will be bright.
Okay.
Every sequence. And for that, you can get a fat suppressed sequence done.
Yes.
So that you can suppress the fat and see the reality, if anything going on behind.
Okay.
You know the reason why we obliterate the cavities with the fat. Why not with the muscle? Problem is, you cannot monitor the recurrence with the muscles, obliterated with the muscle. Because after the muscle obliteration and post-operative MRIs, muscle will give variable signals. You cannot differentiate between recurrence and the muscle.
Okay.
With fat suppressed MRI, if you have obliterated with the fat, suppress the fat, if anything coming up, you can easily pick up.
Okay.
So, It is for the purpose of surveillance, follow-up. The fat is a better material than anything else.
Yes.
Otherwise, your surveillance is too difficult.
And like I was just going through this MRI one.
Pardon?
What they were telling in the diffusion weighted MRI, this is all related with that water content.
Yes. So diffusion weighted MRI, I call it as a bioimaging.
Okay.
Bioimaging means it characterizes the tissue molecular content. In the sense, what does it do basically? Diffusion weighted MRI in between two magnetic fields assesses the diffusion of water molecules. Diffusion of water molecule in the magnetic field. So, tissues having more water content will show more diffusion.
Okay.
Tissues having less water content will show less diffusion. Now, for example, all inflammations, what happens? Huge water content.
Yeah. Yes.
So, more diffusion. All malignancies, with more nuclear cytoplasmic ratios, least water content, see the vessel. Can you see the vessel?
Yes.
Yes, very nice.
Beautiful. लगा दे सच में घुसा दे अंदर यस अंदर घुस नीचे घुसा ना यहाँ घुसा यहाँ नीचे
Which is this vessel?
वो डाल अंदर यस
This is maxillary.
Yes, yes. Yes, you can see the vessel very clear.
Yes.
Acted away.
वो दे मेरे को कॉलेटर दे वो देना डिवाइडर दे
And which coablator wand you are using this? Which coablator wand is this?
Always pro size max. No?
But he removes the electrode, one of the electrodes inside to make sure the suction is wide. Otherwise, pro-size max gets blocked all the time.
What is it? Please repeat, sir.
You see, there is one cross electrode in the pro-size max, which is
that makes your bore narrow.
Okay.
So it gets more readily gets clogged.
Yes.
See, I am deep into the infratemporal fossa.
Yeah.
Yeah.
Give me clip number 1, number 2. Yes, yes. Uta. Hey, come on.
As you already removed the septum,
one more.
Use the scope from the opposite nostril.
Yeah, the one end is in the opposite nostril only.
Okay.
My assistant's hand. See, one clip already there.
Yes.
Section. Either. Leave it. That's it.
Satish, can you please orient us again, please?
Yes. See this. For your orientation, this is your maxillary sinus.
Yes.
This is your right nasal cavity.
Yes.
Nasopharynx. The sphenoid above. See this?
Yes.
This is your pterygoid fossa here.
Yes.
Here.
Yes.
This is the pterygoid process. I have yet to open. Another magic box.
Yes.
And this is your infratemporal fossa. This was the course of the vessel. The nerve above we have already debrided. And above that, this is the greater wing of the sphenoid. See this?
Yes.
which I am going to uncover and if need debride it. The whole anatomy.
Yes.
It is bone. Now,
Mm-hmm.
I am removing this all, bad periosteum, involved periosteum from this bone. This was for the V2, foramen rotundum. This was.
Yeah.
Now, coming medially here. Section रखना यार. Don't do. बोलना फिर.
And after how many days of your this surgery, if you feel the disease may be there, then how many days after the surgery you repeat the MRI or CT?
In case the need arises, not always.
Yes, in case.
In case your clinical picture dictates some residual necrotic area, patient is not improving clinically in spite of the best of the debridement, your CRP is rising. So many factors.
After how many days? Suppose 10 days, 7 days of first surgery?
No, it's not hard and fast.
Okay.
See, this is the greater wing of the sphenoid. This one.
Okay.
Hello?
Yes.
Yeah, Satish. Yeah, we are watching very intently.
And this is the, this is a greater wing of sphenoid, this is pterygoid.
Yes.
Infratemporal fossa is all clear. And now see the...
I want to see that.
Another magic box.
Hmm.
See this huge. See this rotten material. See this what?
Yeah.
See this?
Yeah.
See this? This is, what is this now? Median now. The brighter. And now we have to extensively clear this region.
Satish, please tell us about what you do in the post-operative follow-up. After how many days you do the endoscopy, and what you do in the endoscopy, what you use.
Initially, every alternate day.
For how long?
Until you find that your everything is going perfect. And if you suspect anything
you apply or give wash.
See, Deepak, the follow-up policy depends upon your surgical works. You know, like in otology, everyone has a different policy.
Yes.
And here, simple. Whatever you do, everything will go well if you debride the necrotic area thoroughly.
Yes.
Patient may deteriorate any simple day otherwise, may develop infarcts. So everything depends upon the quality of debridement.
Yes.
What we are struggling here for last more than an hour.
Yes.
See the maxilla clear, the premaxillary area is good, the orbit is clear, infratemporal fossa is clear. Now this whole bone of the sphenoid, all wings of the sphenoid.
In the MRI, it was seen that it is encircling the optic nerve all around in the retrobulbar
bone. Man, see this bone.
Yeah, very fragile. I'm watching here.
See this involvement. Yeah, what was the question?
In the MRI, what you were showing, that in the retrobulbar area, the disease is encircling the optic nerve.
Yeah. Yeah, that will first make the patient blind. Inflammation of the optic nerve is the major reason behind that. 1 hour. 3 घंटा लगे.
And the region, what you said, sometimes there is no disease, but central retinal artery occlusion. You see one case we have seen.
What?
CR, what
is retinal artery occlusion instead of the disease around the optic nerve.
Yes, that is another theory.
No disease is there in the MRI.
Yeah, that happens in certain percent of the cases because this COVID induces prothrombotic situation because of the endotheliolitis.
So post-operative patients, when they are discharged home, do you advise this nasal wash and anything other?
Saline wash. Always. See this bone. This is all avascular bone.
Yeah.
See the area coming up in shape.
Yeah. Really.
What a mess you are. Now see the pterygoid.
What is the role of frozen? If you know clinically it is mucormycosis, then what is the role?
Yeah, if you are in doubt, with this much of convincing, clinical picture and endoscopic picture, no need.
And what we are seeing, Satish, actually I am asking some ऐसे क्वेश्चन जो कि हो सकता है उतना relevant now. What we are seeing, not such aggressive disease, but post-COVID in the CT or an MRI, we are seeing some disease. And when we operate patient, we are not seeing that slough is there. Only mucosal edema and little bit fungus is there. And the KOH smear, they shows non-septate, broad hyphae, what we say. Then we have to give amphotericin.
Yes. So on this picture, you can start amphotericin first of all. There is no, better convincing evidence than what you are seeing. See this, the pterygoid process.
Yeah.
The bone is so bad. See this?
Yes.
Why are you not drilling it, Satish?
Pardon?
Why are you not drilling it? For speed?
Yes. Yes. Section.
You have not answered his question.
Yeah, I didn't get it thoroughly, Deepak. Can you repeat?
He is asking why you are not drilling this area.
Why not drilling?
Yes.
That is to
Just to speed up.
Yeah.
Speed up.
Yes. See this?
Yeah. We can see the marrow.
Yeah.
Backbone.
All bad. See this? Fungus.
Yeah. Inside. Yeah. Very good.
I told you this box, magic box. Debrider. See, you have to be very, very thorough in debridement. That is the key to the overall management.
We are redefining thorough here. What we think it is thorough, but now when we see this, we know it was not thorough.
Your entire results of antifungal therapy and everything depends upon the debridement.
We should telecast your surgery every day. You don't have to comment, but one OT, I think one camera. I'll make a deal with Dinesh.
He'll fed up.
I'll set it up. For the whole week, I think we will keep a certain time slot. I'll talk to you later. This image has to keep going into every surgeon's head. That's what the incompleteness. Now, if you say this is complete.
No, it's still my.
What I mean is.
A lot of job is left behind.
Thorough, because everybody who does up to that point think he or she has done it thorough.
See the pterygoid so badly infiltrated, and I knew this from the MRI. See all the sphenoid floor bone. Oh, the worst part is this disease has an affinity for the sphenoid bone everywhere. Now, this skull-base infiltration, what we are doing,
Yeah.
the most difficult part, and that is the major reason. Ashish, you were asking me to enumerate the reasons for failure.
Yeah.
One of the major reasons. You can imagine now. See, all this is bad bone. There's still a lot of.
So are you going to be going over it with a drill?
Yeah. Now I'm going to go with the drill to flush everything.
I don't think I have the guts to chisel this. I would rather use the drill and.
Pardon?
I don't have the guts to use a chisel here. For me, the drill is a better control.
Yeah, definitely. Drill has a better control. No doubt about it. See, over the period of time, you get used to.
No.
The way you, Ashish, remove the
overhang. I was about thinking about that only. They're using the chisel.
step is overhang.
Yeah.
Something you do so well, you are used to. You know the trick.
Yeah. You know the giveaway, the tactile feel of.
Yes. See the floor of the sphenoid.
Yeah.
There is still a lot of sphenoid bone is infiltrated. Lot of.
One thing always comes in my mind that it will not revascularize if we control rest of the things.
Oh, with the fungus inside the bone.
Yeah, I'm just asking you, brother.
Cannot. See the sphenoid base. Next one is even massive to this. Section. Still a lot of thick bone.
A friend from Pakistan is intently watching and is asking what is wrong with a cutting burr. You will just have to.
Dangerous.
Yeah.
Section.
How far is the carotid?
Very close to where I'm working. See behind there where above the section.
That's why I said I would not.
Here.
Okay.
Dr. Karthikeyan is asking to see the OT setup. I believe he wants to see your assistant. Yeah. Can you?
Karthikeyan is a dear guy. I met him at Mario's place. Very committed guy. worked with Mario Sana recently when I was with Mario last year. Dedicated lateral skull base surgeon.
Gautam from Guwahati is asking, in a circumferential involvement of the orbit, would exenteration be better? Is 360-degree clearance always possible?
Almost always possible. You have a angle divider, angle telescope.
Yeah, and you can retract and go around.
Now in the situation when the outside, I will show you a picture after this case where I'm, planned orbital exenteration. Remind me just moment this case is over.
Yeah.
I will show you. There are indications that the entire eyelid outside socket is involved. Eyeball, eyelid, everything is involved. Then you are not left with any choice.
Until that such a time, there is no need.
Yeah. See now this bone?
Yes.
Now give me the drill. Yeah, not funny. वही रहो ऊपर. See the dead bone?
Beautiful, Satish. Absolutely beautiful.
Okay, in one of the patients, I will show you drilling of the normal pterygoid to see the difference. Okay? So that you can easily differentiate what is bad bone, what is good bone.
Oh, lovely. That no, necros no there. Satish?
Huh?
Entirely necros, no? The whole bone?
Or everything. See
Yeah.
this?
Yeah. Can see it. How to have such a great clearance here?
Yeah. I have not go to the opposite side. This exposure I will improve and show you the drill there. Like last case, I had shown you the drilling of the floor of the sphenoids until we reach the normal area. Bring section book now.
What should one be careful about in this area?
Stay in the midline. Be careful about the carotids. Don't exert any undue pressure. It is just like, shaving.
Yeah, okay.
And keep an eye for the color change.
That's where the carotid is going to be, no?
I am close to the carotid here. A normal clivers won't allow you to drill like this, bloodless.
Far more dense and, bleeding.
Bleeding. Clivers is a very vascular bone. My God.
In this region, I don't even know what question to ask you, so you please comment.
What?
In this area, I don't even know what question to ask you, so you please make your own commentary.
See the vascular bone coming.
Yeah, okay. Yeah, we can see some pinkish tinge, at least medially.
Yes.
Satish, Dr. Joshi here from Pune.
Hi, Samir. Hi.
Hello, sir.
Hi. Yeah.
Thank you.
Satish, I just wanted to ask you, how do you identify that the basilar artery is coming from pavus?
What?
Is the periosteum basilar artery or occipital junction? Far off.
Yeah. That is behind the dura, behind the arachnoid.
Yeah. So we will, just like the posterior wall of maxilla where we encounter the periosteum first, here everything is...
Flat bone has come, vascular bone has come all around.
Yeah. Yeah, Samir, go ahead, ask.
Yeah.
See now the vascular bone. See the color differentiation.
Yeah.
Yes.
It was absolutely dead. If you don't debride, no fun in operating.
Yes, absolutely.
That's why high mortality rates. The reason is, ability to debride this much deep under endoscope is the call. You cannot do this. You cannot do this with open surgery.
Of course.
What will you do with open surgery? This operation cannot be time bound, number one.
Yes.
See now? Yeah. See this bone below is nice. See the healthy bone.
Yes. Now this much bleeding is normally also encountered because of the marrow, no?
Yes, sir. So this is healthy bone.
Yeah.
So it's too much of, I'm very close to the carotids.
Sorry.
The feel can tell you whether the bone is normal or not. See? You feel with the drill. This is now the greater wing of sphenoid.
Yeah.
Yes.
See the normal bone?
Yes, Satish. Yeah. The color and the texture both is looking.
See the?
Yes, the ivory.
Yes. You don't need to be radical. If many a time you find this bone deeply invaded and you have to left with no choice but to remove it.
We don't know
what is up there? The dura. The temporal lobe is right up there. This V2 runs in the floor of the temporal lobe. So now this part is pretty clear. Now let me show you the other areas. I have to go to a little bit to the opposite side as well. Not much. See the sphenoid?
Yeah, Satish.
There is a greater wing of sphenoid, pterygoid, non-existing. See this is the dura, temporal dura here.
Oh, yes.
Glimpse of the temporal dura.
Yeah.
This is the cavernous sinus. orbital apex. See, this is the optic nerve going above. Can you see?
Yes, yes, very nice.
Yes, yes.
Below
Pretty
that is the superior orbital fissure. What is separating them is the optic strut. This superior optic orbital fissure is the continuation of anterior continuation of cavernous sinus. So my carotid is here, right there, and see where I was, drilling.
Yes, yes. Just right there. Yeah.
Now let's go furthermore. Now not much of the work is left. Little bit on the terminate on the opposite side and some work. This is to the septal defect. Now next 10-15 minutes will be through. The next case is ready. Next will be open case.
Okay.
Next case is the open case.
The skin, the one with the skin involved.
Yes. The rider. Just having a look at the opposite sinuses and then take the 70 degree to reach the skull base. Rest of the lateral wall is looking healthy. See that opposite side. Such patients, unfortunately, are getting amphotericin now, liposomal, because of the being out of stock. I'm just doing the sinus work. Don't do the way I'm doing. Now give me, see the skull base.
Yeah.
On both sides.
Ready for a transcriptory form.
Pardon?
Ready for a transcriptory form approach?
No. That's the only work left now. Rest is done. Oh God. People must have fed up with this case.
No, we're enjoying it.
We are enjoying.
In our teamwork, Ashish,
yeah,
our all junior colleagues have done doing good dankers for me.
Okay.
Let me tell you, Dr. Naman, who is the youngest of all, done so many dankers. He does so fast. Very committed guy. Dr. Naman Pincha, Dr. Saurabh Gakkar, Raghavendra, all these guys are doing amazing.
Great, folks. To get a compliment from Satish Jain is a badge of honor. Keep doing the good work. I think you all are lucky to be there.
15 minutes में
See, all until you get the flat bone. Glimpse of the vascular bone, you have to go. See, once your vascular bone, you can rely on the drugs. See that? You don't need to remove everything.
Satish,
Yes.
recently I saw two cases wherein the palatal bone was almost
Yes.
osteomyelitic, fragmented, but
What?
the mucosa overlying was intact.
What?
So
What?
shall we debride the bone submucosally in such cases?
Can you repeat, dear? Sorry, I couldn't.
Yeah. See, I saw 2 or 3 cases where the palatine and alveolar bone was osteomyelitic on CT scan and MRI, and it was fragmented, and to touch also it was little bit, you can say, like a bag of sand or something like that. But the overlying mucosa was perfectly normal.
So what
So
happened?
it's a
That is another area people overlook.
where shall we go in for aggressive submucosal
Yes,
debridement of the bone?
yes. Otherwise, very soon it will present with ulcer.
Okay.
Very soon. That is a common entity we see. The revisions we get. Palatal bone involvement because of the overlying mucosa, one can easily overlook.
Yes.
See with the 70-degree now. The close-up of the skull base now. See the bone? See the cubiform region?
Yes.
Good bone, good bone. This upper part of the septum is not good. Another thing is to develop getting used to identifying the avascular bone. See now? That bone was avascular. One can easily miss. See with the 70-degree, the most anterior part. Ashish.
Yeah, frontal. Yeah. He was also watching, but he was watching on YouTube. He said, "I'm connected. I could not see him. He's just sleeping now."
Who?
Complimented Sethi from Singapore.
Oh, Sethi, boss.
I sent him, no, he's gone now, or he's going to sleep. He just messaged. I sent him the link, because of this having sort of having involved the chief minister, the ministers. I did not send the links to too many people initially. I wasn't sure what their protocols and what. Okay. Okay.
See the fertile?
Yes.
See, this all is required to prevent secondary sinusitis, and these are the reasons for elevated CRP if you don't address.
Which will give you wrong signals. Yeah. Wrong interpretations. Yeah.
See now, everything vascular. How's the picture of the skull base now, man?
Yeah, yeah, super.
Now I can see everywhere vascularity. See the panoramic picture.
Yes.
Satish, his right eye vision is lost.
Yeah.
Pardon?
Right eye.
Right side vision is lost. Yes.
Yes, yes, right side vision is gone.
And MRI is showing us all around optic. Then why you are not showing us that part here in this case?
What?
You're not well audible, Deepak. Just speak closer.
What are you saying? Ashish?
Sorry, I could not hear.
I am asking then why you are not showing us the dissection all around the optic in this case on right side.
Optic now?
Right.
Or around the debridement he did know he was retracting the globe and the optic nerve.
Yeah, I had shown everything. Probably you missed.
With the 70-degree scope, his assistant was retracting and he was debriding.
See this? All inflamed muscles. And no necrotic now. Give me debrider a little bit.
Just some doubt.
Yes. Yeah, there is some area. See orbit there. I had shown you optic now, everything above and below the optic now.
Okay, okay.
See, this is optic now. This one.
Yes, yes.
Like the line. And see the cosmetic deformity you were talking about. Huh? After this work, there is no deformity. Can you see?
Yes.
Yes, absolutely. You can't tell.
Yes, that is a beauty. Orbital clearance. Exentation would ruin unnecessarily. That is too radical.
Excellent job done.
Fabulous. Master.
Still, there is some disease left in the infratemporal fossa. Small. Next case is induced. And again, you will see the lake of mucor in that case. Lakes of mucor. जिस पे लगा देना बाद में ना. Yes, now give me the rider. Now see this area. Some disease. I will remove that part of the greater wing in case required to access it. This is all pterygoid venous bleeding.
Venous plexus.
Yes, sir. See how healthy this area is.
Yes.
Thanks for this. So we'll close it with little layers of the surgical at some other places.
Yeah.
And rest of the picture is.
You will not wash this with amphotericin.
We will pack with amphotericin.
Okay.
Topical solution.
Are you using that amphotericin ointment?
Not ointment, the same deoxychelate solution.
But if somebody is having that amphotericin ointment, is this advisable to use?
You can if it is available. Never used. So that's the final picture you can see.
Excellent.
Panoramic view. Remember when we started what the picture was?
Yes.
So now we will close for us. Put some surgical and something. And we move on to the next case.
Yes, okay. Sorry, I was trying to look for the questions.
Yes, please.
Yeah. Ramesh Rohiwal is asking, is the feel while drilling bad bone, is it little softer? Yes, because it is necrose.
Pardon?
Is the feel of the necrose bone softer than the normal bone?
Yes.
That's what he was asking. Then,
so the next case.
Supposing you get a CSF leak, what next? Dr. Dikshit from Mangalore.
Yeah, you have to close it like you close other CSF leaks.
With the increase in number of cases, many surgeons are doing this surgery with conventional instruments. Any suggestions to them?
Conventional means?
I think he means no coabulator and no drill, no IPC.
Yes. It is difficult, boss, to justify. See, I told you the single most important prognostic factor is the adequate debridement. That's it. For that to be adequate, you need to have an adequate information about the need of debridement through MRI. If you have not done MRI, one cannot justify. However amphotericin you give is not going to work. So the single most factor is the adequate debridement, because the dead bone, dead tissue is not going to be treated by any other means. See now, can you see on the right side? Contrast picture. Can you see? Hello?
Yes.
Lake of Mucor. See the lakes of Mucor everywhere. See, let me come most anteriorly. See the most anterior picture. All swollen, inflamed, with all mucor. See this?
Yes.
See, look at the opposite side, normal cheek. See this, all superficial soft tissue is infiltrated, completely infiltrated. See this?
Yes.
Nasal cavity, all soft tissue, everywhere. Gone, completely gone. See this? Right from anterior to posterior. See the lakes of Mucor.
How is the vision?
Gone. See this? Till behind. See the region of the infratemporal fossa. Let me come from anterior. This is the maxillary sinus.
Yes.
Yeah, the vision is normal. Sorry. See this?
Okay.
Everything involved. Sphenoid. See the region of the infratemporal fossa, the pterygoid area. Let me put the T2 together, then you will understand. See, wherever there is lakes, there is inflammation which is high intensity on T2.
Yes.
See this, go behind all mucor, this hyper intense. Here it is dark, here it is hyper intense. Huge, all see even the lateral muscle, this is lateral pterygoid muscle. See that is temporalis muscle.
Yes.
Compare with the opposite side. See the lateral pterygoid on this side and see the lateral pterygoid on this side.
Yes.
See the temporalis and see the enhancement. Enhancement is acceptable, your drug will work. So you will find all rotten material. Since the skin is infiltrated, so we are left with no choice but to go by open approach, and if we get adequate satisfactory debridement, since it is open, we can assess everywhere. We'll just obliterate with a anterolateral thigh flap with the skin over it to introduce more vascularity.
Lamina in this picture is looking infiltrated at one place, or is it normal?
Now it is, see, it is so preserved. See, the eye is so well preserved. You saw the picture of the eye in the last case?
Yes.
And now see, so preserved on both sides. And left side is almost normal. No sinuses, everything is normal. It is only right side. Huge. Now, a maxillectomy for cancer is different than this maxillectomy for debridement. Here we can go piecemeal. We have to remove all necrotic only, not all muscles. Only necrotic ones. So we can go piecemeal very easily. The palate is gone. See how to differentiate. Another point to mention, whenever you look at MRI, in any regular case, not like such extensive case, if the palate is infiltrated, you can easily pick up. See the picture of the hard palate on both pictures. This is normal hard palate on this side, which is enhancing on contrast. Can you see? What is happening to the hard palate on this side? Loss of enhancement. It is dead. No vascularity. And how will you appreciate on T2? The normal bone is darker and the inflamed bone with the fungus is hyper intense. So crystal clear. So I will show you the entire palate on this side has gone. So pre-operatively, you can tell your patient with MRI that your alveolar process is involved. We have to remove the palate and you have to go with further reconstruction later on with the obturator or further free flap, anything later on, but there will be need. Rather than giving him surprise post-op that we had to remove the palate also. You can tell them, warn them pre-op, counsel them, see the palate completely infiltrated on this side. Is it clear?
Yes.
So, this case is a different one, adding to the different variety. Any questions or anything?
You are going to reconstruct in the same sitting?
Yes.
Okay.
He's sitting, but we will see that on camera. That will be off camera.
Yes. The plastic surgeon would be doing.
Satish, you mentioned about the palate bone being also affected. The same way you look for the difference in the signals for the pterygoid also, comparing to the opposite side.
Yes.
How the bone is involved.
Yes, you can pick up easily. See, let me tell you, here for the pterygoids, good question at the right time. Look at the pterygoid on this side, come to the fat suppress. Look at the pterygoid region on this side. This is fat suppress means the pterygoid marrow which contains fat is suppressed, so it has to be dark.
Yeah, okay.
On fat suppressive. Look at the left side, it is dark.
Yes.
Now, on a fat suppressed image, if you see enhancement, what it is going to be?
Yes, it's yeah.
Disease.
Yes.
This is the best way, or I would say the only way to know the bone marrow involvement. That is fat suppressed MRI. Same exists for the angiofibromas as well.
Yes. Okay, wonderful. Yeah. Because this was they could not decide whether to drill the pterygoids preoperatively in the plan. One should. It's very, very clear that the MRI is telling you that well ahead of time. You don't have to keep guessing during surgery.
Ajay क्या है? Ajay. मिले किस टीम में? एक और इसको जाते एक और.
Have you been getting such advanced cases? You've been doing any external approaches?
Pardon?
No, I'm asking Samir whether he's been getting, because they are also a tertiary referral center. Hello, Samir, are you there?
Yeah, I'm there. I'm getting such advanced cases, but basically what is happening, we don't do reconstruction right in the beginning.
Hello?
Yeah, Satish.
Asking something?
No. I was asking Samir a question while you get ready. Yeah, go ahead, Samir.
Yeah. Facial skin involvement, not too many.
Okay.
Nowadays we are getting, but then palatal involvement, yes, and we keep the palate open.
Okay.
So in this case, in the open approach even, it will not be like a classical maxillectomy for malignancy at all.
Yeah.
We'll be using micro debrider with open approach so that we can debride only bad tissue, not the normal tissue. Microscope. Microscope.
Which flap he is going to use? Anterolateral thigh flap or?
Pardon?
Which flap? Free flap? Anterolateral thigh flap?
Yes. We need bulk as well as lining, and that is the ideal choice here. मेरे फोन से सुमित को लगाना. Hello.
Yeah, Satish.
Yeah, somebody was asking about a need for debridement. What cases? Need for orbital exentration.
Yes, yeah.
Let me show you. Can you focus your?
We are still MRI picture.
Yeah. बहुत जरा कैमरा फोकस करना. ये एक्सटर्नल कैमरा.
Okay.
जूम करना.
Yeah, a little bit center. No, you're going off. Yeah, okay, we can see it now. Perfect.
Focus. The eyelids gone. On MRI, even the eyeball is all involved.
Yes. Oh, the eyeball is also eroded?
Yeah. Everything. The eye inside is full of mucor.
Okay.
Eyelid, eyelashes, everything has to go. And this is the case for exentration and free flap.
Yeah. Okay.
Then about that, intracranial cases, that frontal lobe involvement, all that. See this. Can you focus, please, again? Please focus again. Yes, zoom karo.
Yeah, no.
Yes. Yeah. Clarity नहीं है.
Clarity नहीं है. You hold it.
करो करो. Focus, focus. Focus.
Yeah.
Little more, little more. Can you see? Can you see the fungus going intracranially?
Yeah.
See through and through.
Oh, it's again gone out of fungus, out of focus, not fungus.
See, fungus is there everywhere now. It is like God.
Too many messages.
No, camera should be close up on the mobile.
थोड़ा पीछे ले.
Yes, yes.
Very clearly seen, Satish.
See the frontal lobe, the way it is involved. Let me show you on sagittal. Sagittal will give you better picture. See this. Show this.
Now go close. Yeah, there is a ring of enhancement and there is hypodentia there.
See this. The huge frontal base involvement.
Yes.
Can you see?
Yeah. We can see clearly.
Intracranial component. And a lot of brain edema as well. That is see this?
Yeah.
So such are the most challenging cases. The outcome is poor, unpredictable, possibility of neurological complications, everything is there. So now in a couple of minutes, I'll be back. Meantime, you can carry question.
Meantime, what? I'll also take a break if you don't mind, just.
शेविंग करने वाला तुरंत वे शेविंग वाले को
Camera. Ready? नहीं लगाना, ये पीछे लगा दे सही. No. Hello.
Yeah, Satish. Yeah.
Yeah, Ashish. So we're all set.
Set for the yeah. So you're going to. How are you going to use the microscope camera?
I think that will be better. ये नीचे करना, नीचे टेबल. और हो सकती है थोड़ा. माइक्रोस्कोपिक पिक्चर भेजो. Somebody, microscopic picture. छोड़ दो. Microscopic picture. छोड़ना नरेश, अभी ये दिखाना. मतलब, hello.
Hello, yeah, Satish.
Are you getting microscopic picture?
No, not yet. But the
क्या कर रहे थे?
MRI is gone, so maybe.
Just a minute.
Yeah.
कैमरा तो है ना. हाँ?
Yeah. Now we can see Satish.
चेंज करेगा. लगा. We're changing the camera. Just a moment. Better picture?
Yes, yes, much better. Yeah.
Section. Now see the state of the palate. Look at the status of the palate.
Yes.
See all this. Yeah. See this palate is mobile. See that?
Yes.
All rotten material. See the state.
Already. Yeah, yeah, yeah.
The necrosis. Everything gone.
Yeah.
That's why number one. Number two. No, hata de. See this outside skin is all involved. Involved and fixed.
Fixed, yes. Indurated.
Yes, this is completely involved. The palate is involved. What I will do, I will remove only that much skin which is involved. See what I am showing.
Yeah.
Only that much skin which is involved. Like we mark for the malignancy.
Satish, in malignancy, usually we mark more than a centimeter than the induration.
Yes, obviously.
Here also?
Here not. Here the situation is different. Here the situation is different.
Yes.
Same incision like बीच में मतलब section तक
Satish, here the reason for choosing external approach is involvement of skin, na?
Yes.
Pardon?
Yes, yes.
The reason for choosing external approach is involvement of skin. Otherwise, you would have gone internally.
Yeah. Secondly, the entire palate is gone.
Palate is gone.
There's a huge amount of necrosis. I mean, I don't see any clear advantage of doing an endoscopy for this.
Yeah.
It has been more of a struggle than justifying it.
Yeah. It will reduce the time also.
Yes, this is very fast. And this is indicated for the regions you see.
Yeah.
अच्छा नहीं tongue depressor चौधरी जी ये बोलो बस एक ही काम है ऐसे नहीं है यूं see the necrous tissue I am going around. See this clear tissue, normal tissue. See this? Hello.
Yeah, Satish, we are watching.
Yes.
I'm marking for the palate. Good. Piru? Yes. I hope the picture is good.
It's very good, Satish. We are well oriented, looking nice.
Uh, See, if we are able to remove this disease load, this is a very rewarding patient.
Mm-hmm.
If you remove all this necrotic tissue, see all healthy tissue around. What we are leaving is a healthy tissue, simple. Zero quarter करना सही.
Satish, Rajiv is asking, is there any role of industrial oxygen in development of this fungus?
Oh, no.
Hello?
Yeah, Satish, yeah.
Yes, somebody is asking something.
The question is there any role of the industrial oxygen in development of this fungus?
Not really. A lot of concern these days. Tooth. Badi tooth. See, relating to that, it's not about the industrial oxygen responsible for this. I tell you the reasons. Number one, then it would have given mucor to everybody.
Not just the diabetics and the sugar guys. Yeah.
Number two, this is selectively, specifically targeting those people only who have taken steroids and particularly diabetic. See what I'm separating? The bad tissue and good tissue.
Yes, even there you are.
And now with the open approach, everything is so simple. Action. See this? So bad. This is the frontal process of the maxilla.
Yes.
I am not going to go like a classical maxillectomy, I told you. That's the orbital floor. Section. See the amount of pus there inside everywhere.
Yeah.
See the mucor.
It leaks, no?
This is the zygomatic bone. Now, osteotome. इधर Not doing a classical one maxillectomy. I am cutting from here, and the rest is normal beyond. That's the orbital floor elevation. See that?
Yes.
Look. Yes. What is? What are you? No. One of the gods, please, no?
Going to see the fastest maxillectomy.
Centralized. Okay.
All of them, no? Section. See this? All out?
All
See
out.
this?
Yeah.
Now, this still there is, I told you,
Yeah.
wherever it is involved, we'll remove piece fields rather than a radical, we go in maxillectomy.
Use the debrider.
Yes. See, such a simple procedure.
Not simple, but yeah.
Section, Guru. See, this is the ideal case for open approach. So, we cannot be dogmatic in choosing the approach. This is called butchery.
But in your hand, it still looks like surgery. Don't worry. In your hand, it still looks like surgery. Our young bright star Sai has also joined from Pune, Gauri's daughter.
Doctor?
Sai Belsare.
Sai Belsare, welcome.
Thank you, sir.
She had joined and she left. I thought because we didn't acknowledge her, she left. So I had to tell her, please come back.
No, sir.
No.
I thought there was some audio problem.
No, just kidding. How's your facial surgery work going?
Yes, sir. Right now, there is mucor everywhere, but I'm looking for cases.
Otherwise, you've been doing mucor?
Yes, sir. I'm working at a government institute itself. So we have 15-20 pending cases.
Oh.
Thanks to Jain, sir, we have got a direction now how to go about it.
Yes. I'm really going to, keep his something or the other every day. So what happens, I think, for 2 hours or 3 hours, Satish, I'll talk to you tomorrow.
Okay.
Even even to people on the on Zoom. I think we will have 1 or 2 of his surgeries live. People can watch and people can ask questions because every day people are going to land up with situations And I think this is the best way to utilize the expertise of this man and do good to the patients. So Dinesh, we are going to go every day, and I'll talk to you again tomorrow. But from Monday, we'll work out a schedule for the whole week. The time Satish can decide what. मेरे को म्यूट कर दिया तूने.
Ashish,
Every day, yeah, Satish, go ahead.
can you see the fresh tissue?
Yeah, we can now see.
Healthy tissue.
Yeah, I think you have sucked it out only, the necrotic tissue.
See the part of the septum out which was involved. See the opposite side nose which is normal. See the opposite turbinates.
Yes, we can see the turbinates, yeah.
Opposite turbinates being normal.
Yeah, that's the septum, no?
See, that is orbital 4.
Yeah.
I told you that vision is intact.
It is intact, yes.
And now we'll support the orbit with the flap. There is the periosteum which was little necrotic. See that?
There was a question when the vision is good and you have an orbital involvement with fungus.
Yeah, you have to preserve. Boss.
To approach, yeah.
Vision is good means your vessels are intact.
Yeah.
Your optic nerve is not undergone inflammation. The lesion is away from the optic nerve. We should preserve. See the good bone.
Good, very nice.
Which bone is this? Anybody? This is greater wing of sphenoid.
Okay. Can you please orient us anatomically?
Yes, Ashish, see this. These are infratemporal fossa muscles. Yes. This is your nasopharynx, you see.
Yes, yes.
This is Eustachian tube here. Eustachian tube.
Can appreciate, yes.
This is all infratemporal fossa muscles with the bone nibbler.
Okay.
ये नहीं दूसरा वाला. See this? The bad tissue behind the bone.
Yes, yes.
इधर गया तो उठा. See all these necrosed bone. बोला ना दूसरा वाला. See this?
Yes, Satish, yeah.
Now let me do sinus surgery.
Okay.
This is your sphenoid sign. This is the rostrum. This is mass, microscopic sinus surgery. Ashish. Ashish. Hello.
Yes, we can hear you. Yes, we are seeing Satish.
बुला ले प्रदीप जी. हाँ कोई बात नहीं वो बोल दिया उसको हेलो
Yes,
आशीष अच्छा फोन पे
we can hear you and we are seeing.
No, I can see. Sorry, I had muted. So yeah, Satish, yes.
So this is MES, microscopic sinus surgery. This is your sphenoid sinus.
Yes.
Below is the nasopharynx.
Yes.
Okay.
Yeah.
This is your eye here. This is your lamina.
Yes.
Ethmoids. See this?
Yeah.
That is the skull base. And above is the frontal. See everything clear?
Yes, Satish. Very nice.
Healthy. Here I am in the frontal. Here. Lamina is good, healthy. That is orbit. Now the last part left is roof of the infratemporal fossa.
Again, right up to the dura you have to go.
Yes. See this, all sinuses, full house fats.
For all those watching now, I think this will be our last case. Satish has about 10 or 12 cases more before he can go to sleep. We are going to let him go and go off camera so that he can finish work. We'll come back. Yeah.
All necros.
All necros, yeah. So you're going beyond. Can you centralize a bit? Yeah, thanks. I'll come out with some schedule with, I'll talk to Satish and then to Dinesh. And I think in the interest of this current program for Mucor, we'll have Satish online on Zoom doing his live surgery at least 2 or 3 hours or 4 hours in a day. People can watch the surgery live and also keep asking him questions. Because each day will have some challenge or some question that needs to be answered. And I think, Satish,
Yes, dear.
we will come out with something which will do good to everybody and to the patient. Oh, beautiful.
Okay.
Yeah.
See all necrotic material. See this?
Yeah. Unbelievable. Yeah.
My goodness. See all this.
Yes.
All. This was the picture you saw, the lateral pterygoid muscle.
Yeah.
That is the pterygoid process.
Yes, that's correct.
See, that's the lateral pterygoid plate, that's the medial pterygoid plate.
Yeah.
And this is the lateral pterygoid muscle. This is temporalis.
Okay. He must be thinking of the Labe myoplasty.
See, simple again.
Yeah.
This is your Sona. This is your angle of mouth. Okay?
Yes.
What Labe says, this temporalis is coming over here.
Yeah.
On the coronoid.
Yeah.
Here on the coronoid.
Yeah.
To mobilize here to the
Angle of the mouth.
modulus. Modulus of the lip.
Lip, yeah.
Just from here to here.
Yes.
By means of elevating the posterior part of the temporalis from above.
Correct.
Breaking the zygoma and releasing it from above.
Yeah.
You can do that. That is lengthening myoplasty. Temporalis lengthening myoplasty.
Part of the orbital floor.
Yes. See this?
Yes, still next.
Brother. This is high infratemporal fossa.
Okay. Almost under the zygomatic, no?
Pardon?
Almost under the zygomatic.
Yeah. Can you repeat?
Is it almost under the zygomatic arch?
Yeah, zygomatic is far laterally.
Ah.
It is far deeper. Section. Zygomatic arch is here.
Yeah, okay, okay.
Here, superficial. Now coming to the pterygoids. See, this is sphenoid sinus.
Yeah.
Orient yourself. You saw last time the pterygoids
Yeah.
in the anterior-posterior plane. See this, like the endoscopic picture. This is sphenoid.
Yes.
This is your orbital apex. This is greater wing of sphenoid above. And this is your pterygoid. This is pterygoid process.
Okay.
From the lower part of the pterygoid process, this muscle is going to the angle of mandible. Anybody?
Medial pterygoid.
This to the inner surface of the angle of mandible.
Medial pterygoid.
Yes, medial pterygoid muscle. Now what I was doing there endoscopically for the pterygoid process has to be done here. Okay?
Yeah.
Yes.
See, rest of the things are clear now.
Yes.
Nothing is left.
Yeah.
All healthy.
Yes.
Okay?
Yes, sir.
See, all healthy. Everything healthy. Under control. Yes.
Satish, what about the frontal lobe? We are going to stage it.
Frontal?
No, that's not the case. That's a different case.
Achha, that's a different case. Okay.
Yeah.
That will be done tomorrow.
Okay.
See this pterygoid involvement.
Yes.
See the disease in the bone. See this.
Yes, we can see, but centralize a bit. Yeah.
It is full of disease. Full of disease.
Full of disease. Yes.
That is normal marrow above. This is the last part and it is done then. Final. See the normal marrow.
Yeah.
Normal marrow.
Yes.
Normal marrow.
Yes. 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 Yes.
Ah, final. See the normal marrow. Little bit of the fungus.
Yes.
Your suction is the key. Can you see this normal marrow red?
Yes, yes, we can see.
This is good. No more disease. That is the foramen for the V2. See the foramen rotundum.
Yes.
This is Vedian canal.
Show the
This
video.
is foramen rotundum. This is Vedian canal. This is the nerve here.
Yes.
Lateral, infero-medial in the pterygoid process. Yes, this is all normal. Nothing is required to be done now. Debridement over. See the normal palate. Palate you saw, it was disease. All necros on this side. So थोड़ी वो देख लेना hemostasis. This is normal palate, you can see.
Yes, Satish. Yeah.
See the bleeding.
Yeah, absolutely fine.
So our reconstruction will involve this. The skin, as well as will fill with the vascularized tissue to give additional vascularity. Okay?
Thank you, Satish.
So we can come to questions if anybody has.
Wait, let me check. But I have
Satish, amazing speed.
There was nothing in it.
And it's a teamwork. You have somebody to take care of the plastic, and you have somebody to take care of the pre-op. So it needs to be built over a period of time. All the centers.
Pre-op, post-op, counseling.
Yes. मुझे ऐसी लग रहा था कि दशावतार होते तो इंडिया के पूरे केस खत्म हो जाते थे. Satish Jain.
Oh.
Yeah, true, very true. But Abhi, he has 10 more to go.
Yeah, that was me. See, amazing stamina, instruments भी इतने होना है. Very nice.
So now our 4 theaters started simultaneously.
I was called by your team to say, Abhi, इसके बाद sir को free करो. So because you have another 10 cases to do. And this is so it's okay.
So any questions, any suggestion, anybody?
The only people asking about amphotericin, can we preserve the skin if it is like cellulitis? Injection amphotericin can work.
I'm quite sure Ashish, amphotericin will be available soon.
Yeah.
This and our government is making sincere efforts.
Yeah.
This morning I got the call from our chief minister. Then his secretary to CM, first CM himself, then the secretary.
Yeah.
He said we are making, war level efforts to ensure the availability. And there was a huge discussion regarding, importing from other countries.
I think they are very sensitive now because of, what they've gone through remdesivir and, other things. So they know the mechanism of sourcing it at a global level. And they know how to talk to the pharma to start ramping up. So I'm sure that interim period, those few patients are going to be unlucky. I hope it gets probably at higher price, but we will get. The same in Maharashtra. I think our chief minister also is very, very alert medically. So, I mean, I don't think any minister will sit for 2 hours watching surgery and listening to the talk so intently. I'm sure
Suppose if the amphotericin is not available, then what we do? Can you suggest some?
Other formulation, combination with posaconazole, isoconazole, other non-liposomal formulations, there are alternatives. There is no other option.
Really, I mean, it's for the physicians to find a solution, I think, to that.
But still, it can be prevented from now.
Yes.
At least whatever happened has happened. You can't revert it. Besides, making the public aware to present at the early stage. Earlier, high-risk people who were administered steroid like anything were never informed to present to ENT in case you have early symptoms of this disease, because they never knew this could happen. So, but now having known everything, there is a time to make the public aware to present at the earliest symptoms of the nasal phase so as to prevent blindness and mortality. Still is the time. Second is to prevent prescribing steroids on the OPD basis without glycemic control. Only under strict glycemic control, probably by admitting the patient, but still that is a big problem. We start admitting these lakhs of patients, we don't have that much number of beds. So the problem is, from all around, it's difficult to manage. It's not all that easy.
They can manage the glycemic control even in the OPD and at home levels.
At least we should tell our patients to.
So I think that there has to be a public outreach program for controlling hyperglycemia and daily glycemic control. I think where we have gone wrong is they thought that it's okay for it to be up for 3-4 days or something every day, and therefore I am very hopeful that we are looking at a 6-week window. If from today or whatever in this week the physicians start checking of the taking care of the sugar levels and use steroid really, really judiciously, I think 8 weeks from now the incidence will drop. This 8 weeks, whatever is my hope, and my God knows I'm.
And see, in this category, if you remove the mild cases, if you include only those cases with moderate to severe disease with cytokine storm suggested by the investigation, you choose steroids on those cases. Even the government can make registry to track those patients, warn them, and all those things. There still is a time to prevent in future.
I think 8 weeks. By 8 weeks, we will start seeing a severe decline. Is my hope. Because now people will, those are still have had that no control and steroids, they will still keep presenting for the next 8 weeks, and after that, hopefully, they will start coming down.
Yes.
आशीष आपके मुंह में घी शक्कर.
Yes, sir. Thank you. Yeah. Okay, then Satish, I think we should call off. Let you go.
Thank you all.
Thank you.
Thank you
very much. Yeah. Thanks, Satish. I'll talk to you tomorrow.
Okay.